How come I can hear my own voice?
Arup, you are fine. Continue.
Perfectly all right.
Yeah, no, I can hear the echo. So that's what. So
No,
the
we
code,
can't
the
hear you.
webinar. Yeah. So this masterclass is titled IOL power calculations. IOL power calculations in part 1. Okay, right. So I am Arup Chakrabarty, editor cross-settings AIOS, in charge of this course, and helping me out as a moderator is Dr. Nazneen, who is also a panelist along with Dr. Sri Ganesh and Dr. Pankaj Sharma. We have a lineup of great speakers, legends in the field, who have made IOL prediction much more accurate, and are passionate teachers who have been teaching us for the last couple of years. We have a great Indian faculty, again, people who are extremely passionate about IOL power calculations, and they have been teaching in the various platforms in the country as well as abroad over the last couple of years. Now, this is a very important webinar, very important topic. There are a lot of issues that have to be dealt with. And for us to do justice to the webinar, we have divided into 2 parts. Part 1 will basically deal with the basic issues. It is a very important segment of the webinar. It is the stepping stone to the second part of the webinar, which will be held sometime in the future, where we'll be talking about the unique or the complex situations. And the showstopper, or one of the most important facets of the program today is the keynote address by Dr. Dow Thok. He will be telling us about correcting astigmatism with Toric IOLs, preoperative, intraoperative issues, and analyzing the outcomes. A couple of weeks back, June 13th, we did another webinar on video bouquet of echo, basic to advanced part 1. And it is streaming live at various platforms, and it has been recorded, and you can view it in the YouTube channel of the All India Ophthalmological Society and Editor Proceedings. You can subscribe to it, and I would take this opportunity to thank Dr. Mahipal Sajdev, the president of AIOS, for facilitating this particular webinar. Dr. Mahipal is also the chairman scientific committee of IIRSI. He's the chairman and managing director, Center for Sight Group of Eye Hospitals. He is a very tall leader. He has been a great surgeon. He has been a pioneer, and he has been leading the All India Ophthalmic Society very, very confidently in these troubled times. My thanks also go out to Professor Dr. Namrata Sharma, Secretary of AIOS. Thank you, Dr. Namrata, for all that you do for All India Ophthalmic Society. Dr. Namrata, again, is a very prolific publisher. She's a good surgeon. She's an excellent speaker. And she has bagged plenty of awards, national as well as international, and a lot of awards under her kitty. So thank you, Dr. Namrata. And I would now take the opportunity to introduce to the audience the distinguished faculty members. Dr. Dow Thok is the professor of ophthalmology at the Allen Mosbacher and law chair in ophthalmology at the Kalena Institute, Baylor College of Medicine. His clinical and research interests are in cataract and refractive surgery. He has taught over 250 residents and fellows, authored over 200 articles and book chapters. He has given 31 named lectures, the Jackson Memorial, Kelman, Binghorst, Barracker, and the Lance lectures at the AO annual meeting, Charles Kelman Innovators Lecture, and Steiner Refractive Lecture at the annual meeting of the ASCRS, Binghorst Medal Lecture at the annual meeting of the ESCRS, and the Arthur Lim Lecture at the APSCRS. He is also the editor emeritus of the Journal of Cataract and Refractive Surgery. He is the past president of the American Ophthalmological Society, the ASCRS, and the International Intraocular Implant Club. Dr. Marjan is a professor of clinical ophthalmology, director of cornea, refractive and cataract surgery, vice chair of Ophthalmic Faculty at the Gavin Herbert Eye Institute, University of California at Irvine. She graduated summa cum laude from UCLA with a degree in biology and earned her medical degree at the University of California at San Diego. Her clinical practice is divided between patient care, teaching, and research with focus on corneal surgery, specifically the use of the femtosecond laser for corneal transplantation. She is also the founder of the Severe OSD Center at UCI and performs limbal stem cell transplants and artificial corneal transplantation for the treatment of patients with severe OSD. Dr. Farid serves as a board member for Sight Life Eye Bank, is the vice chair of the Scientific Programs Committee of the Eye Bank Association of America. She is an active member of the Cornea Clinic Committee of ASCRS. She has published numerous articles in peer-reviewed journals, authored multiple textbook chapters, and travels extensively to present her work at national and international levels. Dr. Hanbor Pham is a good friend of ours. He is a senior consultant and founding head of Cataract Implant and Anti-Segment Service and senior consultant in the Refractive Surgery Service of the Eye Institute at the Tan Tock Seng Hospital in Singapore. He is an API-CRS certified educator with more than 600 presentations in international and regional conferences. He has conducted more than 50 instruction courses and masterclasses and performed 5 surgeries throughout Asia. He has sat in more than 70 expert panels. He has published in the prestigious peer-reviewed journals, including JCRS, Journal of Refractive Surgery, AJO, and BJO. He has been a co-author of the book, A Clinician's Guide to Slit Scanning Corneal Topography, and a contributor to the book, Corneal Topography from Theory to Practice. And I would like to introduce Dr. Nazneen as a brilliant ophthalmologist. She has done a fellowship in medical retina and glaucoma, single-handedly established glaucoma clinic at a hospital, has keen interest in neuro-ophthalmology, has several presentations, review articles, posters, book chapters, and publications to her credit. With these words, I would hand over the stage to Dr. Nazneen to introduce the rest of the faculty members. And after that, we will have words of introduction from our esteemed President and Secretary of the AIVS. Over to you, Dr. Nazneen.
Good evening and welcome to this webinar. Can you see my slides?
No, Nazneen, we can't see your slides.
I put on share, but
just stop the share and share again. You can't. Just stop share once and then share again.
Have you opened the first slide?
No, Nazneen, you've come to the end of the slideshow.
Yeah, you
go up. You go up. You've come to the end of the slideshow. You've come to the end of the last slide you're showing.
Yeah.
Yes. No.
We can see it now.
Yeah. Click on the first slide and then.
so good.
Yeah, now it's right.
Slideshow, put it into slideshow, Nazneen, from bottom right, put it into slideshow.
From current slide.
Yes. It's gone again. Okay.
Just hit F5. It will start the slideshow.
Okay. Do as you did previously. That was okay.
Just click the up arrow, Nazneen. The
The
up
slides
arrow
are-
on your keypad. The up arrow on your keypad. Just click that.
Or at the bottom left, there would be an arrow right side, left side. So click the left side, bottom left. Yes, click the left side arrow. Yes, click this. Yes,
Yeah.
now you're on the
Go up.
clicking, keep clicking. Yes, yes, perfect.
Thank you so much. So good evening, and I welcome you all to this webinar on IL power calculations. First of all, I'd like to thank our President, Dr. Mahipal Sachdev, and Professor Namrata Sharma for giving me an opportunity to present here, and Dr. Arup Chakrabarti, Editor Proceedings of AIOS, and the Chief Instructor for this course, for giving me a chance to be a part of this webinar. I'd also like to thank Microvision for arranging this webinar for us. So first of all, I'd like to introduce the panelists first. Dr. Pankaj has completed his post-graduation training in ophthalmology from AIMS, and he's the senior professor in the Department of Ophthalmology at AIMS, where he also heads the cornea clinic and eye bank. He has performed over 30,000 successful cataract and IOL surgeries. He has numerous national and international publications, and he has been the guest faculty in major national workshops and conferences. Dr. Shri Ganesh is our second panelist. He's the chairman and managing director of Netradhama Super Speciality Eye Hospital. His main interests are cataract, phacoemulsification, and refractive surgery. He has numerous publications in international peer-reviewed journals and has been conferred several awards like the Honorary FRCS and the Doctor of Science Award. He also has the Colonel Rangachari Award for the overall best free paper in AIOC in 2016. Dr. Arulmozi Varman is the founder director of Uma Eye Clinic, Chennai. He's a pioneer in microsurgery and IOL in the country. He has a special interest in phaco and multifocal IOLs. He has conducted over 150 phaco training courses globally. He has presented papers and has conducted instruction courses in various national and international fora. He has been the treasurer and secretary of the Tamil Nadu Ophthalmic Association. Dr. Ramesh Dorairajan is the senior consultant ophthalmologist at Sundar Eye Hospital, Chennai. He is the secretary of the Madras City Ophthalmic Association, and he has conducted several workshops on different aspects of biometry in regional and international conferences. Dr. Girish Jetwa belongs to the milk city of India, Anand. He has a rich experience of over 37 years. He was the first to start trip and blue staining in cataract surgery, and he has several presentations in AIOS, ASCRS, APACRS, and ESCRS. I'd also like to invite Dr. Jayanthan, who is the head of the Department of Refractive Surgery and Pediatric Ophthalmology in KSI Hospital. He's an alumni of the Arvind Eye Hospital, Madurai. He has a special interest in pentacam, keratoconus, and dry eye management. He has presented several papers in national and international conferences. He is also the winner of the BPOS award. Dr. Anurag Mishra is the director of Radharaman Hospital, Cuttack, Orissa. He has 2 long-term fellowships under his belt from Aravind Eye Hospital, Madurai, one in IOL surgery and the other in pediatric ophthalmology strabismus. He has been invited faculty in various meetings and he has performed over 30 live surgeries. Dr. Shandas heads the cornea and the anterior segment services at Shushruth Eye Foundation, Kolkata. He has graduated from Kolkata Medical College and has done his post-graduation from PGI. He has done cataract surgery training from Lahan, Nepal. He also has a cornea fellowship observership from Orbis under his belt, and his special interests include complex cataract surgeries, combined surgeries. So this is the overview of the program. The first talk would be the overview and standard operating procedures for optimal refractive outcomes by Dr. Arup Chakrabarti. This will be followed by Dr. Fareed's talk on optimization of ocular surface prior to biometry, the ACRS preoperative algorithm. Dr. Jayanthan will be talking on keratometry pearls, and Dr. Shayan will be speaking on topography pearls. Ultrasound biometry will be covered by Dr. Arulmozi Varman. And Dr. Anurag Mishra will be talking on optical biometry. Dr. Hanbor Sam will give us an overview of the various formulae, the older as well as the new ones. And Dr. Douglas Cock will be speaking on correcting astigmatism with toric IOLs, preoperative and intraoperative issues. Dr. Ramesh will be enlightening us on the concept of effective lens position, IOL power step, and manufacturing tolerance. And this session will be winded up by Dr. Girish Chetwa, who will be talking on a constant optimization. So I'd like to invite Dr. Arup Chakravarti first for his first talk. Thank you.
No, before I go for my talk, I would request Dr. Mahipal Sachdev, our esteemed president, and then AS Secretary Dr. Namrata, to say a few words.
Thank you very much, Arup, and indeed grateful for you to arrange such an excellent galaxy of speakers, I would say, for this masterclass. I think you have picked up and chosen each of these speakers as also the topics, and IOL power is something that keeps on getting refined, and we are ultimately reaching the target emmetropia for majority of our cases that we are doing. I would say that the faculty is really fantastic. Dr. Farid will be covering about optimization of the ocular surface. Dr. Pham, we have all heard, and we have the Indian faculty, as you can see, Pankaj and Shri Ganesh would be the panelist, and we have lots and lots of great Indian faculty. But I think, as you said, whether you call him the showstopper or whether you call him the I'll say the jewel in the crown, somebody that we have been in a couple of meetings together in the advisory board, and whenever Doug says something, everyone listens with so much of rapt attention, and these are words of wisdom that come out of him. I've always been very fond of him and have tried to get him over to AIOS or IIRSI meeting, sent him invites, but for some family reasons, he's not been able to come to India. But Doug, it's great to see you on the digital space and giving your words of wisdom to the All India Ophthalmological Society members. I'm sure that what you have contributed to ophthalmology is beyond parallel, and really fortunate to have you to speak to the Indian audience. So Arup, great for you to have put up this masterclass, and we also look forward to the next masterclass. And over to you, and all the best for this particular webinar.
Dr. Namrata.
Thank you, Dr. Arup. Thank you for organizing this excellent webinar on a very complicated and a very important topic, IOL power considerations masterclass, and that too doing it so comprehensively in 2 parts. I'm sure both of them are going to be complete in themselves, and it is going to be very exciting when you combine both of them together. I would like to welcome Dr. Douglas Koch from Cullen Eye Institute. It's an honor and a privilege for us to have you here, and we are all looking forward to your talk. I would especially like to welcome Dr. Marjan Farid, a great friend of mine. We've been in several DSEC courses and keratoplasty courses together. Thank you, Marjan, and once again, it's lovely seeing you. I would also like to welcome Dr. Han Bor Pham from Singapore, and would be looking forward to his talk and his contributions. It gives me immense pleasure to welcome Dr. Pankaj Sharma, my very good friend, and he's my batchmate from RP Center AIMS. We share the same alma mater, so a special, a special thanks to him for coming here, and it's always lovely to see you. It is a pleasure to welcome all the other faculty, which include Dr. Jayanthan from KSI Hospital, Dr. Sayandas from Sushrutai Foundation, Dr. Arul Moi Varman from Chennai, Dr. Anurag Mishra from Cuttack, Dr. Ramesh Durairajan from Chennai, and Dr. Girish Jetwa from Anand. So I'm not going to stand in between the program, the show, and the speakers. So I think Dr. Rupi can start. And Dr. Shri Ganesh also. I forgot to mention Shri Ganesh because I see him so often.
Okay. So thank you, Dr. Mahipal and Dr. Namrata, for the very kind words of introduction. I was hearing some echo from my laptop when I was giving the introduction to this webinar. Then I realized that a YouTube channel was running on the background, and I was able to hear my own voice. So now I have switched it off, and I think things are okay now. So I'll set the ball rolling by giving an overview on this topic and also lay down the roadmap for this webinar. Nothing financial in what I'm going to talk to you about today. Now, all of us cataract surgeons would like to hit the bullseye in our postoperative patients more often than not. The holy grail is plano 6/6 most of the time. And before I move further or go further, I would like to acknowledge the 4 guest editorials published in Journal of Cataract and Refractive Surgery over the last couple of years, which have basically redefined the way we think about IL power calculation and has given a new direction, a new dimension to the entire process. And one of the contributors, Dr. Dow Kaup, is amongst us today. And the other contributors also include big names: Warren Hill, Adi Abulafia, Lee Wang, and Jack Holliday. So what we have learned is IL power calculation is not just a one-off event in the lifespan of a cataract patient. It is a process, it is a method that transcends the perioperative period. So there are issues in the preoperative period that we have to bother about, intraoperative incidents, and the postoperative phase. So preoperatively, before we embark on the biometry as such, it's important to examine and evaluate the patient properly, looking into the sources of vision loss and factors that could influence the accuracy of IL calculations. We all know that the tear film is the strongest, most powerful refractive surface of the eye. And if there's any disturbance on the ocular surface, that is going to adversely impact the IL power calculations. And we have none other than Dr. Marjan Farid, who will be talking to us on this topic and give us the ASCARA's preoperative algorithm and the US perspective on this topic. So patient counseling, as always, is a very important aspect, because it's not always that the patients look for the emmetropic target. You know, there are some of us believe in monovision, and then the refractive targeting would include a little bit of myopic correction, myopic target if you're thinking about some of these premium intraocular lenses, for example, the external depth of focus lenses, extended depth of focus lenses. And biometric measurements, we have learned that it should be done from multiple devices, 2 to 3. I, of course, don't advocate more number of devices, because, you know, there's a law of diminishing returns, and then, you know, you really do not get any enhancement by using multiple devices. Again, I would recommend the use of multiple IL power calculations, and what exactly, how should we go about it? We'll wait to hear from Dr. Hanbor Pham and Dr. Dow Kaup after the talks are over. And after all these exercises over, we finally come down to selection of the right intraocular lens for the patient, which is going to be implanted in the patient's eye. Now, intraoperatively also, it has been a very standard. Almost all of us perform cataract surgery through a 2.4 millimeter temporal clear corneal incision. We make a rhexis, which is 5 millimeters in size, ensuring that there is a 0.75 to 1 millimeter overlap on the optic edge of the rhexis margin. In certain situations where the capsular bag support is compromised, for example, if we keep a lens in the sulcus, we may think about optic capture. If a lens is in the bag, we may think about a reverse optic capture or optic capture through the posterior rhexis. Or if there is no bag whatsoever, we may have to think about intrascleral haptic fixation, different types. So here we need to tinker with the intraocular lens power. And all these will be dealt with in the second part of our webinar in maybe next month. So we also have heard that intraoperative aberrometry has pros and cons, and it does well. There's a lot of publications that are coming on this topic. I am sure we'll be hearing about these things from Dow, as well as, you know, the guidance systems to orient toric intraocular lenses. Many surgeons use them. There are many surgeons who don't use them. They just use the manual slit lamp technique, slit beam from the slit lamp to orient the toric intraocular lenses. So postoperative period is the moment of truth. moving beyond the anatomic outcome, we look at the refraction. And if there's an unwanted residual refractive error, the operating surgeon himself should be in a position to take care of it. Again, this discussion will be postponed to a subsequent date. So basically, how did the IOL power calculation all begin? We all know about Sir Harold Ridley, 29th November 1949, the first IOL was implanted. And on the same day was the genesis of the IOL power calculation and the refractive accuracy related matters. So anatomically, the cases did extremely well. But when the results were published in the BJO, the first audit cycle revealed highly myopic outcomes, minus 21 diopter and minus 15 diopter spherical equivalent. And in the second audit cycle also, the median postoperative refractive error was quite high, minus 2.25 diopter. So definitely, there was a long way to travel for us to refine the outcomes. If you look at the Royal College of Ophthalmologists cataract surgery guidelines, it says that 85% of the patients should be within 1 diopter of target refraction and 55% within 0.5 diopter. But I think we need to go beyond that. And at this stage, I'd like to refer to the presentation made by Dr. Warren Hill, the Charles D. Kelman lecture in the AO meeting in 2015, where he presented results from his database of more than 2.6 lakh eyes, which were worked out with Huygens formula, triple optimized for each surgeon. And the results are pretty interesting. The vast majority of the surgeons using this database would land only 70% of the eyes within a refractive accuracy of 0.5 diopter. And less than 1% of the surgeons were able to reach this level of accuracy in the 92% of the eyes. So there was a long way to go. And if these are all normalized, now the results were even worse when you dealt with eyes with extremes of axial length or post-refractive surgery eyes. There's another interesting, important publication that happened in the JCRS August 2016, soon after this presentation, which compared the visual outcome using 9 IOL power calculation formulas using optical biometry, and it revealed that the refractive correction, the refractive accuracy was between 75.1 to 80.6 using this multiple formulas. So definitely we are making progress from what we are achieving before that. Coming back to, again, Warren Hill, his Rayner Medal lecture presentation, where he presented his report results on Hill-Arbier formula. Only highly skilled surgeons were included in the study, and they operated on eyes with axial length mainly between 22.5 and 24.5 diopter, using a sophisticated optical biometer with careful scrutiny of the raw data. Results were really astounding. Now, there were 90% of the eyes, the surgeons were able to land within the plus 0.5 diopter of the target refraction. So definitely we have come a long way. And then this is the latest publication that happened. I mean, I just want to trace out how the refractive outcomes, how the refractive accuracy evolved over a period of years. Can you hear me? Okay. So this was actually published by Savini et al. At the JCRS in January 2020. And here again, you see the results are pretty good. 84% to 90.67% of the patients were getting within a error of 0.5 diopter. And some of the formulas which did extremely well are basically very new formulas. You have the Kane formula, you have the T2, you have the EVO formula. And older formulas also did pretty well. Not as well as the newer formulas, but pretty well. So when you compare this study to the previous studies, the uniform theme was the refractive accuracy was getting better and better. So now what led on to this kind of situation? So we had newer instruments, more sophisticated instruments coming into the market, which were able to measure the dimensions in a much more accurate and precise manner, in addition to giving more number of biometric parameters. And the current formula, the older formulas have changed their version, they have been updated, and the new formulas came. And we have, again, understood the full significance of A constant optimization. And all these will be covered in the subsequent topics. There are a couple of the newer instruments will be discussed during the course of this presentation, and we have no financial interest. There were in 1999 we had the first optical biometer coming in, IOL Master 500. Then there was a series of similar standard optical biometers that came in. So the question arises, is there any one particular type of biometer superior to the rest of the biometers as far as the standard optical biometers? There are multiple publications in the literature, but what caught my attention was the one published in BJO, which compared the Aladdin and the Lenstar and found out that there was a high level of repeatability and agreement between these two devices. Many of us have gone into the swept source OCT-based optical biometer. And again, the question comes up, how does it compare with the older generation, the previous version of the optical biometer, the 500? So again, I refer to the BJO on the 2015 issue, and it said that there's a good agreement between the two devices. And of course, there are certain advantages of the IOL Master 700 over the IOL Master 500. So what I'd like to tell here is, the affluent countries or affluent practices can afford to go in for the sophisticated latest generation devices, which come with a cost. But the developing countries definitely still have to make do with the existing technology, the equipment that are available in the older technology. And we have lined up a series of talks based on how to get maximum output, maximum results from the limited options that we may have. So we have Dr. Jayanthan talking to us on keratometry pearls. Sayan Das will talk to us on tomography pearls. We have Dr. Arul Moli Varman, who basically uses IOL Master 700, but will be telling us about the pearls related to ultrasound biometry. Then we'll move on to optical biometry pearls by Dr. Anurag Mishra. We'll not be talking about how to do the test, but what are the do's and what are the don'ts and how do we optimize results with these technology. And I would also again refer to these guest editorials which were published over the last couple of years, and they gave a very good perspective of the formulas. What we learned that after the first theoretical formula that was published way back in 53 years back by Fyodorov, there has been a series of formulas that have come up, and then we classify them chronologically. This is a mixed bag. Most of the time this classification doesn't make much sense. So today the tendency is to classify the formulas based on the method of calculating the IOL power and the data that they use for these calculations. Vergence formulas have become very popular. Artificial intelligence formula, the Hill RBF definitely is making waves, and we are going to have the version 3 released in a couple of weeks' time. The ray tracing formula, though many of us don't use it, the Oculus are the Phaco optics because maybe they're the paid formulas. So, but we are told that they are the future of IOL formulas. Now, there's one enigma here. Now, our generation has grown up using Holiday 1, Hoffa Q, SRKT, Higis, and then came Barrett, Universal 2, Hill RBF. And we are told that, the last two formulas should be enough for most of our purposes. We don't have to use multiple formulas. But if you see the recent literature, last 3 or 4 years, there has been multiple new formulas that have come up. As you see here in this chart, there is the Kane formula, EVO formula, Panacea, Pearl DGHS, Nazer, T2, and many of these formulas have been doing extremely well if you go by the publication, the reports published in the literature in the last couple of years. So we definitely like to have some clarity on this from Dr. Hanbor Pham, formula overview, and he's going to take us through and suggest to us what exactly is the formula that we should be using. Then we'll move on to the masterclass by Dr. Dow Koch. As Dr. Mahipal has already mentioned, that he is a renaissance man in this particular field. I have listened to his talks when he delivered the Jackson Memorial Lecture, the American Academy, and multiple named lectures. And he has really revolutionized the way we think about IOL calculations, particularly Toric IOLs. And we are very, very eager to listen to you, Doug, in your presentation. And we also now feel that, the formulas have come up pretty well. The biometric results are becoming more accurate. So the industry also has to keep pace with us and move along. So we need to have a situation where perhaps Ramesh will throw more light on this. Instead of having a lens available from steps in parts of 0.5 steps, we need to have 0.25 steps. The industry also needs to look into the IOL manufacturing tolerance. So Ramesh will be telling us about IOL power steps, the concepts of ELP, how important it is, and the manufacturing tolerance. And then we'll talk about the lens constants. See, even if you use the most sophisticated equipment and the best formula, if your lens constants are not fine and not properly done, you lose the game. Your results are going to be very, very inaccurate. And the importance of examination length also has been driven home. We have realized that if you have the lens length of more than 4 meters, it is okay. Anything less than that, you have to use a particular formula to find out the spherical equivalent refraction for the patient. And we'll have none other than Dr. Girish Jetwa talking to us about A constant optimization. So with these words, I wrap up my presentation, and then I would request Dr. Marjan Farid to get going with a talk on ocular surface disease and cataract surgery. Over to you, Marjan.
Thank you so much. Do you see my presentation there?
No, not yet.
Not yet. Okay, let me see if I can get that up for us. Wonderful. Do you see that now?
Yes, yes.
Wonderful. I wanted to say thank you so much for having me. It really is an honor to be part of this prestigious faculty, and thank you to the organizers, especially to Dr. Namrata Sharma, who is a friend of mine, and I've had the honor and privilege of watching her operate. She's an amazing corneal surgeon and a wonderful teacher and amazing mentor. So, and the rest of the faculty, of course, thank you all for having me here. So we will start today's talks on the ocular surface optimization, which I think is really one of the most essential things to getting all of the IOL power correct, because really, if you don't have a pristine ocular surface, everything else, really none of the formulas will work, and it just becomes a challenge from there. So let me see if I can go on here. These are my financial disclosures. I'm a consultant for several of these companies. So I'm going to start the talk with a case. This is a 76-year-old woman who presented to our clinic with blurry vision and glare, and said, doctor, I have cataract. I've been told I have cataract and I want cataract surgery. My friend no longer wears glasses. She has this fancy intraocular lens, and that's what I want. And her symptoms correlate with cataracts. She has poor night driving vision, but she also says that her vision gets worse at the end of the day, especially after reading and watching TV. And when we ask her, how do your eyes feel? She says, fine, doctor, there's no problem. And she has no other symptoms. So we start our examination. Her visual acuity is down. She does glare. So all of this is consistent with cataract surgery. But when we go to look at her ocular surface and exam, she has significant meibomian gland dysfunction, very thickened secretions, minimal expression of her glands with significant punctate keratitis of her ocular surface and a very rapid tear breakup time. And of course, she does have a significant cataract as well. So I was part of this committee, the ASCRS Cornea Clinical Committee, when we sort of thought about how do we set more guidelines to really capture patients within this preoperative setting who have ocular surface disease. And how do we start? Not every practice will have all of these different diagnostic tests, but what are some of the essential ones to help us identify ocular surface disease in this patient population? And then where do we go with treatment, especially because each patient is individual, each patient will have their own constellation of signs and symptoms, and how do we really gauge our treatment once we have identified these patients? So I know this is a very detailed slide, but this is sort of an overview, and we'll do an overview of what these guidelines really tell us. One of the essential things to remember is that dry eye disease, ocular surface disease, really leads to potential errors in preoperative measurements. Topography can be incorrect, keratometry, refraction, aberrometry, all of those measurements, if you don't really have a good ocular surface, will be incorrect. And besides that, we do know that dry eye disease, blepharitis, for example, will increase the risk of surgical infection rates. Surgery itself will worsen dry eye disease. So if you can turn a patient who was asymptomatic dry eye disease and turn them into a very symptomatic dry eye disease, if you don't address this before surgery. And the patient will often contribute that to a poor surgery. So even if the surgery went wonderful, they have a great lens, if they feel worse after surgery, they will say, doctor, you did something wrong because now my eyes feel terrible. So it's so important for patient satisfaction and post-operative outcomes to really capture these. Now, the other interesting thing is that most patients in the preoperative setting will be asymptomatic. So these patients, this is a study, several studies actually have shown this now, but up to 60% of routine cataract patients were asymptomatic, yet 50% of them had central corneal staining. So a significant majority of patients in this preoperative setting will present, they will be asymptomatic, yet they will have signs of ocular surface disease. So, one of the things I do routinely, and I really urge all cataract surgeons to do, is to have some kind of a questionnaire in the preoperative setting to be able to capture patients who might otherwise not contribute their symptoms to dry eye disease. And we use the SPEED2 questionnaire, which was also we had adjusted that a little bit to include questions that might help us gauge whether the patient is a good candidate for something like a multifocal intraocular lens. But ask the patient and really delve into these questions to identify. So at this point, if we've seen ocular surface disease, I think it's important to stop the cataract workup and further evaluate the ocular surface to really be able to categorize the severity and the type of dry eye disease in these patients. So the look, lift, pull, and push, LLPP, very important. Look at the lids, look at the ocular surface, lift the lids, look under the lids, pull, look for things like lid laxity, and then push on those meibomian glands to look for the quality and the rapidity of the secretions from the meibomian glands. And of course, we stain the ocular surface as well as part of this to assess for ocular surface staining with vital dye. And here, again, this is just a short video demonstrating, so important. Sometimes you can't really assess by looking at the lids themselves. They may look fine, but if you really delve further and push on these glands, you realize, as you can see there, that they are really inspissated and the lipid layer is really of poor quality. So we did an initial IOL master, had been done before the patient got into the room with me. And you can see one of the other red flags in this is that there's a big difference between the keratometry between the two eyes. So you see very less than 1 diopter of astigmatism in one eye and over 2 diopters in the other eye. That should also send up some red flags. And this patient specifically wants spectacle freedom, so maybe wants something like a multifocal intraocular lens. So given this significant ocular surface disease, really don't trust the initial biometry measurements and further evaluate the ocular surface. How do we do that? Certainly a point of care testing is great if it's available to you. Looking at tear film osmolarity can certainly help identify patients who have tear abnormality. Our patient had an osmolarity in the right eye of 318, left eye of 306. And again, that puts the patient on this scale of dry eye disease. The intraocular variability is also another red flag. I like to look at a tear film inflammatory cytokine markers as well. The MMP9 test is great. Our patient here again was positive for MMP9, telling me that there's an inflammatory component to the tear film. And I love meibomian gland imaging. If you have this available to you, I think it's so critical. And the patient loves to, I think, and will help get them on board with their disease state because they can really understand, yes, this is normal. And this is, my lid looks abnormal. I can see where I have meibomian glands that are shortened, that are thickened, and areas where there's dropout of clear meibomian gland structure. So our patient had a significant dropout there. And then the topography, finally, look at the Myers. These, if there are irregularities, wavy lines, areas where they're missing, this is another red flag that the tear film is not good and really needs to be further assessed. So what is our treatment? We've now identified our patient as a significant ocular surface disease patient. How do we start the treatment? Where do we start? What do we start doing for these patients? Really, our goal here is to reduce the surgical delay time. So I want to treat these patients aggressively, maybe a multifaceted approach, treatment regimen, so that we can get these patients turned around quickly, the tear film, and get them back for repeat measurements and into surgery. So versus a regular dry eye patients where I may add on things one at a time, in this setting, and this is what the ASCRS algorithm emphasizes, you don't need to go one step at a time. You can really take this multifaceted, more aggressive procedural and prescriptions into your treatment plan to turn around the tear film quickly. So again, now in terms of inflammation, so we have inflammation, we have oil glands that we need to address, and we want to clear up the punctate keratitis on the surface. Lots of anti-inflammatory options. We have our cyclosporin formulations, which we all know well. And there are multiple, even in the pipeline that help sort of in the more longer term, help reduce the overall tear inflammation. Lifitegrast may work a little bit faster by working at multiple steps in the inflammatory pathway. I won't go into too much detail in the interest of time. I love steroids in this population of patients for short term, because you do get a rapid turnaround of that inflammation in the tear film. I use a lodiprednol formulation, but something that is maybe a low potency with a lower side effect profile, certainly, and better tolerated, maybe less preservatives in the formulation. I use something like a 4-week to 6-week taper, again, to really turn around that inflammation quickly. Oral tetracyclines are great as well, especially if there's significant ocular rosacea and lid inflammation involved. Importance of treating the lid margin, the oil gland, I think is very essential, because we know the lipid layer is really one of the most important to create that smooth surface for our measurements. So relieving the chronic stasis and obstruction of the glands is really essential to improving tear breakup time. And, I start every patient on hot compresses at home and give them full instruction on how to do that. Despite my best efforts, we know many patients do not do this at home, so compliance is sometimes an issue. And sometimes it's also difficult to really reach the adequate temperatures for sustained periods in the oil glands with just anterior hot compresses. Blepharoexfoliation is great, especially if there's a lot of debris on the lid margin, lid cleansing and ointments. In-office procedures, thermal pulsation type procedures, there are multiple approaches now. I do like to offer these to patients who I think can benefit, again, in the preoperative period from a more rapid expression of those oil glands. So something like LipiFlow, there's iLux, MiboFlow, Tear Care System, all of these essentially heat and squeeze, get those oil glands flowing again. Omega-3 fatty acids, I think there has been a lot of up and down in our understanding of whether or not they help with both inflammation of the lid margin as well as normalizing lipid layer. And I think with more recent meta-analysis that was done, I believe in 2019, it really looked at multiple randomized clinical control trials, that the final decision here is to, yes, they do help with improving both symptoms and signs of dry eye disease. And so I do still recommend omega-3 fatty acids, something like a reesterified fish oil for patients to improve the inflammation of their lid glands. And then there's adjunctive treatments, things like autologous serum, which has been shown in multiple studies to also help with severe ocular surface disease and dry eyes. You need to have a good phlebotomy lab and a compounding pharmacy to be able to produce a good product, but I've seen a punctate keratitis turned around on the ocular surface very quickly with the addition of autologous serum drops, so I like to use that. Fresh frozen amniotic membrane, self-retaining in patients with very severe punctate keratitis, I think is a good adjunct in certain patients to quickly sort of clean up that ocular surface. So I do use those in some cases as well. So the summary of our action plan is really to initiate a multifaceted treatment, treat the inflammation, the oil glands, and some kind of a regenerative, whether it's serum or Procara, if there's significant punctate keratitis, to turn that around. I re-see these patients in about 2 to 4 weeks to assess how our treatment is doing, if we've turned around the ocular surface, and at that point assess whether or not they're ready for biometry and IOL power decisions and calculations. But I always, I think the other part is counseling and education for these patients is very important to keep them on board with compliance. So our patient was started on loteprednol and lifitegrast. We did a lipid flow treatment. We started the patient on a course of doxycycline orally, and took them all off of preservative drops and put them on preservative-free artificial tears. And when we compare our IOL master results after 1 month of aggressive treatment, we can see here, using the holiday formula in this case, that really it turned around not only the spherical component, but took a patient that we thought might need a toric intraocular lens to not needing a toric in the right eye, and a lower power toric lens in the left eye. So we saw a change in the sphere and the astigmatism in the eyes with good treatment of the ocular surface disease. The impact, this is a paper that was done by Dr. Epitropoulos and Matosian on 25 subjects with known dry eye disease based on osmolarity, that the biometry after 3 weeks of treatment had significantly changed. There was a higher variability in keratometry rate pre-treatment and post-treatment in these patients, more than 1 diopter of difference between the readings, and a higher percentage of patients that needed at least a half a diopter change in the IOL power finally after treatment. So really, really essential. We're going for perfection in these patients in terms of hitting the bullseye, as we talked about earlier, and you can't do this unless you treat the ocular surface. So again, importance of patient education, getting them on board so that they adhere to the recommended treatment regimen. And in conclusion, really important to identify these patients firstly, and they won't identify themselves. So it's more important in these patients to look at signs, not symptoms, because symptoms will be lacking in a majority of patients. So look for the signs. And then again, a multifaceted aggressive approach to delay surgical time and improve preoperative biometry. And certainly the last thing we want to do is turn a patient who was asymptomatic dry eye patient who did not know they have dry eye disease and now give them dry eye disease with cataract surgery. The patient often, again, blames the surgeon for that. So we really want to avoid doing that. And so that's my sort of review on how to address these patients in the preoperative setting. Again, I thank you for your time and attention. Thank you.
Thanks a lot, Dr. Mahajan, for the wonderful overview. Nazdin, if you can show up those questions. We actually pulled together a number of questions from the feedback that we received. And if you can stop your share screen, Nazdin, you can share your screen. And then we'll have an opinion from you as well as the panelists about the responses to those questions. Nazdin, can you show those questions? Or maybe you can just read them out, I mean, if...
First one was what is the effect of tear film on keratometry and biometry? That was the first question.
Yeah, absolutely. So we saw that, this one paper that I showed by Dr. Epitropoulos and Matosian is one, but I think we see this in practice as well, that it can be significant, that more of these patients who have known dry eye disease by osmolarity, if you don't treat them versus treating them and look at the difference in IOL biometry, there's significant intraocular variability in their keratometry rate. And more of these patients have at least a half a diopter change in the ultimate IOL power that you choose. So it can really have a significant impact.
The question was, how long would you like to treat the patient before taking up the patient for cataract surgery?
Great question. And I'd love to hear from the panel as well. Usually I bring these patients back in a month. But again, the more severe patients may take longer than that. But again, this is where education becomes important, because you don't want the patient to give up and say, I'm just going to go somewhere else and do my cataract surgery. I really want to keep them within the practice. So I see them back within a month and then reassess.
What about Dr. Pankaj and Dr. Sri Ganesh?
Yeah, I was just wondering if the tear film is not that stable. Can we do the keratometry with the shine flow imaging? Because that usually bypasses the tear film, and it just takes photographs, and it gives much more accurate results, I feel. What would you say, Doctor?
No, I agree. Certainly, there's different types of topography, tomography that we can do, shine flow, but I think ultimately they can all give us an error if there is significant tear breakup time that is rapid and irregular. So absolutely, in cases where my hands are tied and I can't improve the surface beyond a certain point, then of course I do shine flow topography as well to really get the best I can get. But those are then patients that I may not select for multifocal. If I really hit a wall where in terms of how much I can turn around and I still feel the ocular surface is not pristine the way I want, those are patients that I may steer away from a multifocal optic.
Yeah, and the other thing is that even if the ocular surface is not so good, post-operatively the patient won't be happy. So we might as well treat the patient first.
So another question to the panelists would be, if a patient has a coexisting pterygium, Sri Ganesh, and a cataract, then what would be your approach for it?
So I think the pterygium has to be dealt with always first, and then you have to see that the ocular surface is optimal before you go ahead with the cataract surgery, because many of them do the cataract surgery and then say, okay, this is the pterygium is kind of stationary, but the pterygium itself can give rise to astigmatism. It distorts the tear film. So ideally, in our practice, we always deal with the pterygium first before doing the biometry, allow the tear film to settle. There's another very interesting story. A couple of years ago, when we got our IOL Master 700 and they installed it, and then our biometrist was taking the K readings, we also were checking with the other device, with the IOL Master 500 and the keratometry. And then they came to me and said, somehow the IOL Master 700 is not very accurate. The K readings, we are getting different K readings. And what they were doing is they were taking the auto K and then taking the axial length and then calculating it. And then I went there and then looked at the IOL Master and then installed it directly under the air conditioner. And so the patient used to sit there and then they used to enter the details of the patient, and then that used to alter the tear film, and then we had variable K readings. So this is, and then once we kind of shifted the machine, then it was more accurate. I was wondering, how come this is a more expensive equipment? How can the Ks be off? And so this is a very nice story. I have a lot of biometry stories like this, and this is a very important where you install the biometer, and then you should look at the environment and see that. So the ocular surface is very important. You can be off by adapter or so, or adapter or two also. So it's very important that you optimize the ocular surface before you take up the patient.
Thank you so much, Dr. Sri Ganesh. I think we'll move on to the next topic. It is Dr. Jayantan. We request you to talk on keratometry pearls. Dr. Jayantan?
Yes, sir.
Can you share your screen?
Yes, sir. Just a moment, sir. Table and all. So, can you see the screens?
Yeah. But we can't see your slides.
Just a second, sir. I'll reshare.
করবেন একটু পরে, আমি একটা মিটিং আছি, 9টার পরে ফোন করব।
Sunil, can you just help us out? I think he's having some issues with this share screen of feature.
Yes. Doctor, can you just open the presentation and then do screen share and select the presentation and then share?
Yeah, sure. I'll do it.
When you do the share screen, just select the presentation and on the right hand side bottom, press the share blue button after you've selected the presentation.
Yeah, just a second. I'll just try.
Press the share screen button. You will have the window. Perfect, sir.
Yeah, fine. Thank you. Good evening to everyone. I would like to thank Arup sir for this wonderful opportunity to be a part of this star speaker panel. I'll be talking on the keratometry. So we know that less than only 1% of the surgeons are able to achieve a refractive outcome within 0.5 diopters of target spiro equivalent power among at least 90% of the patients. The reason is the key here is success in the good keratometry, because each diopter of error in the keratometry can give rise to a 0.9 diopter of error, that is 1:1 ratio of error. Known sized object. The cornea actually acts like a convex mirror. So from the size of the image formed by the anterior surface of the cornea, that is the first Purkinje image, the radius of the curvature of cornea is actually calculated. A keratometry uses a relation between the object size, the image size, the distance between the reflected surface and the object, radius of the reflective surface. When you have three variables that could be measured, or is it a constant, we could take the fourth one. Wash-and-learn keratometers have a fixed object size. So if we measure the image size, then we can calculate the radius of curvature. The Javel shots have a fixed image size. So when we have the object size measured, we'll have the radius of curvature measured. Right. To start with the measurement, the first thing is to have a very good alignment. The forehead, the chin, and the canthus marker all should be aligned properly before even you start looking into the keratometer. Next, once you start looking into the keratometer, the key here is to focus the eyepiece. An incorrect focus can lead to up to 0.2 millimeter of radius change. This is what the patient sees, and this is what we see. So once we have the alignment, we can adjust the horizontal dial, vertical dial, and this is a focused Maya. The first thing is to actually bring the cross reticle into the right bottom corner of the circle, and then you can rotate the horizontal dial to have a horizontal alignment. The minus sign is for the vertical alignment. So once this final alignment is done, you can read the horizontal meridian with axis, the vertical meridian with axis. In case if you are not able to actually merge these two plus signs, it says that is an irregular astigmatism. So rotate the whole instrument either clockwise or anti-clockwise, and finally have an alignment. Perfect. So we are done with the measurement. Now record both the horizontal and the vertical measurement in eighth of a diopter. Record the flatter meridian at its axis, steeper meridian at its axis. The main point here is to record the clarity of Myers. The biggest advantage of having a manual keratometry is that you can see the clarity of the Myers. Make sure it is clear. Mention whether it is clear or distorted. Always record the finding to 2 decimal points. Total of 4 digits. Normally, a keratometer ranges between 36 to 52. So if you want to increase the range, you can increase the range by keeping a plus 1.25 diopter or a minus 1 diopter lens. So the main this thing here is to deal with the problems that we face when you're doing a manual keratometry. If you are completely unable to locate a keratometric Maya, it says that instrument on or the patient is not aligned properly. Make sure you align and then do the keratometry. In case if your Meyer is seen, but the clarity is getting transiently changed, it may ask the patient to blink and measure it quickly, or put a drop of artificial tears and redo it. In case if the focus is been changing frequently, ensure that the patient's forehead is secured against the headrest. In case if the patient gaze is unsteady, make sure the other eye is patched and then remeasure. If the horizontal and vertical Mayas cannot be measured concurrently, it says that the patient has got an irregular astigmatism. If only one minus sign is visible, then it says the patient's eyelid is drooping. Ask the patient to open the eyes widely and then remeasure. If only one plus sign is then, the occluder is on the way. Push the occluder slightly and then remeasure. Limitations of keratometry, we know that measurement refractive status of a very small area of the cornea, just the 3 millimeters. It ignores the peripheral corneal zone, so even a keratoconus could be missed here, which is slightly paracentral. The accuracy is lost when you are measuring a very flat or a very steep cornea, which holds good for our post-refractive surgery patients. A small corneal irregularities would preclude the use of a keratometer because of the induced irregular astigmatism. Remember, an astigmatism is a vector. Any device that measures astigmatism will need to measure both the magnitude and the direction of astigmatism. So in case if there is an irregular astigmatism, the direction of astigmatism is not going to be right with a manual keratometer. So manual keratometers are very good for your magnitude, but always remeasure with other mechanism to get the direction of the astigmatism. One position instrument assumes a regular astigmatism. Posterior corneal surface is not measured, and an assumed corneal index may cause a problem when you are going to actually interchange the K between the measurements. Common mistakes that we make is inadequate instrument calibration, incorrect examination technique like unfocused eyepieces, distorted Mayas, off-axis measurements, corneal abnormalities like an eyelid interface, irregular contours, inadequate patient fixation or a cooperation, examiner having an uncorrected refractive error leading to a fluctuation accommodation and an error. Clinical pointer is that always make sure the equipment has been calibrated periodically. Whenever you have a doubt, whenever there is a measurement to measurement inconsistency, very flat or steep cornea, inter-eye difference of more than 1.5 diopters, K1, K2 difference of more than 3 diopters, if you have a difficulty in obtaining measurement, validate your measurement with another examiner or ask the patient to come on a different day and do the examination. Always do the keratometry prior to any procedure which involves a corneal contact. It is also advisable to avoid use of anesthetic drops, stains like fluorescent, since these can alter the ocular surface characteristics. It's good to actually use artificial tears. Coming to the automatic keratometry, it focuses the reflected corneal image on an electronic photosensitive device, which instantly records the size and computes the radius of the curvature. We know the advantages of autokeratometer, but the main disadvantage is with automated measurement, the acquisition is static. As a measurement operator, you have no appreciation of the accuracy of that particular measured moment. We'll see an example. You can see this is an image of the same patient. Here, the acquisition is taken perfectly on the visual axis, but here you can see it is off axis. Luckily, this patient didn't have any corneal scarring or any pterygium involving the visual axis, so that it is going to be the same. But in case if the patient has got any pathology, if it is an off-axis measurement, you're going to have a wrong measurement. So be careful to look at the images also. If the Mayas are not crisp and clean, the validity of all the other corneal measurements, including your IOL power calculation, is going to be diminished. And one more point with the automated keratometry is any automated keratometer comes with two modes, automatic and manual. If you have any difficulty, especially in cases where you have a mature cataract, the fixation is not good, go for a manual mode. And you have an R and a K mode. R, it takes, in the RK mode, it takes actually 3 values and averages it, but in a K mode, it takes more values. It's always better when you have a cataract patient, you have to take only the keratometry, go for the keratometry alone mode. The optical biometers will start with the lens star. It is based on the low coherence optical reflectometry. There are 32 points which are actually checked in 2 zones. First zone is at the 1.65 millimeter and second one the 2.3 millimeters. So when you are personally doing, like what I do, personally do the examination, you can see the clarity of the Maya, repeatability of your keratometry and the axial length on the screen itself. But in case if you are not doing it, if you are only getting the calculation sheet, we ophthalmic surgeons frequently accept without any question the corneal curvature powers, the values that we obtain from the values. But see here, we don't have any validation points at the keratometry here. So there are 2 windows. One is the calculation window, next is the measurement window. I recommend everyone to go back to the measurement window and check for the standard deviation. It is always important to check for the standard deviation, and at the below, you can have a check for the image quality as such. Only if the standard deviation is good and the image quality is good, proceed on to choosing your IOL. Okay, so this is one example where you can see the measurement, actually the quality of the image is not good. There is an ocular surface disorder. You can see there is absolutely no repeatability of the keratometry, and as seen by the standard deviation, it is absolutely abnormal. So when you see here, you can see that the standard deviation is very high. And when you go back to the corneal imaging, you can see that the Mayas are distorted here. There is an increased tear film height. So obviously you have to discard the value and then redo again. So two most common causes is one is ocular surface abnormality, second is a lid cover. So always make sure you check for the quality of the image and then proceed with your IOL calculation. Next is IOL Master 500. It has 6 examination points in orthogonal pattern at 2.3 millimeters. So we'll go to the clinical presentation. So this is one another value. As you could see here, there is even the axillin has got a validation point, but the keratometry doesn't have a validation point. So we'll just see, okay. So we'll go to the measurement window. I'll just compare this. This is what the calculation window gives, and this is what the measurement window gives. We'll start from the left eye. As you can see here, the standard deviation is fairly good. Nothing too much to say. The validation window is actually perfectly fine. No error marks here. And the average of the K1, K2 value and the axis is perfectly matched. We'll come to the right eye. As you can see here, the right eye, the standard deviation seems to be perfectly fine. But when you see the error mark, there is an error mark here. Out of the 6 Myers, 1 Meyer is completely not actually calculated. So there are 2 measurements. Normally, IOL Master takes 3 measurements and averages it. When you take these 2, it seems to be fairly same. But when you take this value, it is 48.15. So in case if the second value is right, then naturally you're going to be offset by at least a quarter diopter in your IOL calculation. And if this is going to be right, you're going to be offset by more value. Leave alone the magnitude, come to the axis. Here it is 52, 53. So when you take an average, it has to be 52 only. But since the axis is wrong here, the final calculation axis is also 10-degree offset. So at the beginning, in case if this patient is going for a toric IOL, at the beginning of your calculation, you are already offset by 10 degrees. The results are not going to be convincing as we are going to. So in the manual mode, as you can see here, there is a traffic light signal. The green says it is perfectly on focus. Yellow says it has to be focused a little bit, and if it is red, it's completely out of focus. The error markers are, as you can see here, it's a trial time sign, which is a sign of the ocular surface abnormality. You can see the lashes coming on the way. So it says the lid is also drooping for the patient. And you have to actually treat the dry eye as a patient to widely open and then redo it again. Seeing a multiple reflection is also a sign of having an ocular surface abnormality. As you can see here, out of the 6, you can see only the 4 Myers. So it says that the eyelid is drooping. You need to ask the patient to widely open, or if the patient is not able to open, slightly lift the lid. Make sure you are not indenting on the globe and then redo the measurement. And finally, this is a case where you can see there is a localized corneal abnormality, so that the Myers are not clear in the inferior temporal quadrant. So in any of such a situation, switch to the manual mode, don't do an automatic mode. And we are going to take 3 values, and in between every measurement, ask the patient to blink, make sure the tear film is smooth, and then go ahead. If it's not possible, it is okay to actually give a little light artificial tears, which can smooth the corneal tear film. And always remember, more viscous brands can add up too much of tear film, making the tear reflective surface irregular and unstable. Never go for a higher viscous brands. IOL Master 700, it gives a telecentric keratometry. This is the anterior measurement. This is the posterior measurement. The swept source OCT pattern actually measures the posterior corneal surface. This is the only instrument which can actually measure the posterior corneal surface and give a true total K value, which could be incorporated into the Barrett true K formula. Coming to the pentacam, pentacam is not a substitute for any of the keratometry values which you're going to do with the standard mode. This is actually something like a bigger picture where you can have assessment of the corneal health completely. When you have a peripheral thinning, when you have a keratoconus, when you have a pterygium scars, post-keratoplasty patients, you can actually see what's happening for the patient. Two main important thing is, remember, there is no ocular surface detected. You can't see for the clarity of the Myers in a sheen fleck, so it is not going to support you on that way. Second thing is the same case, simulated K values, it is taken in the whole corneal value. So this cannot be given or used in any of our IOL power calculation. But one important thing is you can use the steep K values when you're actually using or going to do a toric IOL. The second important thing about pentacam is that the tomography value, the EKR value, the equivalent K keratometry values that you're going to see in this chart. So you can see the value throughout the cornea, and the best advantage is that it can give the values in all the zone right from the 1 mm to the 7 mm. 4.5 is what we normally use, and this values is actually given in a chart format. It has been distributed in a chart format, and you can see that you can have a flat or a steep point here. So when you have a very strong peak, especially in cases of post keratoplasty or post-refractive surgery, when you're planning for a toric IOL, it is also prudent to have a steep peak here. In case if it is not there, we can see the values. The K mean value is 47, which will be used for the calculation, but the peak is at 47.8. Though you have a perfect correction of your cylinder, you may end up having some amount of spherical error for this patient. So the perfect is going to be something like this. You can have a steep peak at this point. So to conclude, to make a keratometry as accurate and as consistent as possible, we must limit this task to a single instrument for all your preoperative and postoperative measurement. Kindly understand all the working of an instrument and then go ahead. So make sure you calibrate the instrument periodically. Validate all your measurement before you finally conclude a conclusion. In case of doubt, always make sure you replicate the values at multiple points. Thank you.
Thanks a lot, Jayanthan. It was very nice. And I would request Dr. Sayan Das to put up his slides on the share screen. And in the meantime, Nazneen, is any question to be asked for Dr. Jayanthan?
Is the scarred corneas when manual and auto-K both haven't been able to provide readings, how to proceed? What to do?
Ma'am, I can't hear. I didn't get the question, ma'am. Can you repeat?
In case the cornea is very scarred and the manual and the auto-K both haven't been able to provide readings, what to do and how to proceed?
So in this case, we can actually try with topography, ma'am. So topography will definitely give a value, but naturally, if it is a paracentral scar, definitely you will have half of a cornea, which will be good. So you can take the help of a tomography. Tomography will definitely help in this regard, but the values has to be actually used with much of a caution, because exactly using a tomography value into an IOL pair calculation may end up in errors.
Dr. Pankaj, what would be your
Yes,
approach?
actually, the topography would help mostly, but here we use a shine flow imaging also, because that will also give the posterior corneal irregularities in these cases. So we might have a better understanding of the cornea. And I had one more question. In your practice, how many, what percentage of patients come up with a significant posterior corneal astigmatism with the IOL Master 700 as compared with the shine flow imaging? Which would you say is more accurate for?
You to unmute yourself, Dr. Jayanthan.
Yes, sir. Yes, sir. Sir, to be very frank, this tomography and your IOL Master 700, getting a patient, I mean, like, it is not so frequent. It is very rare. Only in cases where we have a post-refractive surgery or a patient who's got a keratoconus post C3R coming in for a ICL calculation, we see a little bit of difference. Otherwise, I mean, like, most of the other routine patient who walks in for a surgery, we don't see much of a difference here, sir. The number of what we calculated is very less here, actually.
Okay, thank you, Dr. Jayanthan. So, Sri Ganesh, yeah.
Yeah.
We'll take the last comment
you
before Science starts his talk.
You get this problem with the scarred corneas when you want to do a combined procedure, when you want to do a combined keratoplasty and cataract surgery, when you have a scarred cornea and then you're not able to get the K readings. In that situation, what we do is we take the K readings of the other eye and then calculate the IOL power, because anyway you will be doing a keratoplasty, so that is kind of approximate if you're not able to get accurate K values. And the other point I wanted to make is that don't interchange and use K values, because different devices have different zones. Like the IOL Master 700 uses the zone of 2.5 mm for the K values. The Lenstar uses 1.65 and 2.3. And if you are going to take your topography, it's 3 mm simulated K. So it is better not to, but there are some formulas like the Barrett multiple K formula where you can put in 3 values from 3 different equipment and then it takes the median. And that, in fact, in publication is shown to be a little more accurate. So these are different ways, but generally in normal practice, it's better not to interchange and stick with one.
That's a good point, Sir Ganesh. Yeah, then we'll move on to the next speaker, Dr. Sayan Das. try to confine to your time limits, 10 minutes.
Good evening, everyone. I wish to thank Dr. Arup Chakraborty and AIOS for giving me an opportunity to be a part of this very key webinar. And I'll be speaking on corneal topography and tomography for IOL power calculation. So as we know, corneal topography is a two-dimensional study of the curvature of the anterior corneal surface, and the devices we use for topography are usually placido disc-based. While corneal tomography is a three-dimensional study of elevations of the anterior and posterior corneal surface, and being three-dimensional, it also gives us an ability to measure the thickness of the cornea. The most common devices we have for corneal tomography are OBSCAN, which is scanning slit beam device, and the Schleimpfeck devices like Pentacam, Sirius, and Galilei. The placido-based corneal topography use multiple concentric rings which are projected on the cornea, and the image is reflected from the tear interface. The edges of the ring, the light and dark rings, are detected, and their distances from each other are analyzed. And the smaller the distance between the edges, the steeper that portion of the corneal surface. While for the elevation-based corneal tomography, the elevation is measured from a reference surface, and this reference sphere is generated on a particular eye and is unique to that eye. And the reference sphere may vary from one eye to the other. So what are the roles of topography and tomography in IOL power calculation? The most important is probably screening of patients for premium lifestyle IOLs. We can plan incisions to control pre-existing or induced astigmatisms. We can assess spherical aberration for choosing aspheric IOLs. We can assess posterior corneal astigmatism, and we can also measure corneal power under certain difficult conditions. Screening irregular corneas. We know that any refractive correction, be it spectacle glasses, contact lenses, or IOLs, it can only correct regular astigmatism. It cannot correct irregular astigmatisms. And aberrations induced by diffractive optics of multifocal IOL can worsen existing aberrations in an irregular cornea. So we have to know which are the normal topography patterns in which patients we can use these lifestyle IOLs. So among these standard patterns described by Rabinowitz, the round oval and the symmetric bow tie are considered to be normal pattern, and they have a round oval or a symmetric bow tie regular astigmatism. Coming to the second use of tomography, topography in IOL power calculation or biometry or achieving emmetropia, we can use it for incisions like tanning to reduce pre-existing corneal astigmatism. And this incision can be clear corneal incisions, which can be single or paired, can be limbal relaxing incisions, or they can be astigmatic keratotomy or AK incisions. Determining spherical aberration and correcting for spherical aberration is a bit complicated. We know that the average corneal spherical aberration, or SA as it is called, is plus 0.27 microns with a standard deviation quite large, 0.1 micron. And the effect comes into play when the pupil is a little big, more than 4 millimeter. That is in the mesophic or a scotopic situation. Here, because of the spherical aberration, if the spherical aberration is high, there will be decrease in contrast sensitivity. And this spherical aberration, and so do other wavefront changes, derive largely from the anterior corneal surface. And this corneal spherical aberration can be calculated from a Q value, which is generated by most topography and tomography machines, and keratometry values. This is only one option for measuring corneal spherical aberration. We can also use wavefront aberrometers for measuring corneal spherical aberration, or the spherical aberration of the entire eye. Q values measure corneal asphericity, and from there, and the keratometry values, there are mathematical formulae from where we can measure corneal spherical aberration. And the normal values of Q, which measure the corneal asphericity, range from -2 microns to -4.5 microns. Now, what we know is these aspheric IOLs can be used to neutralize positive spherical aberration of the cornea to increase contrast sensitivity, as I have said, particularly in a mesopic condition. And different aspheric IOLs have different spherical aberrations, and they can be actually chosen under particular situations. So the IQ IOL from Alcon has a negative spherical aberration of 0.2 microns, Technis has 0.27, and the Envista series from BNL is said to be a neutral aspheric IOL without any spherical aberration of itself. So when the image quality is critical, that is, we need a very high contrast sensitivity, we should use a negative spherical aberration IOL to negate the positive corneal spherical aberration. Whereas when the depth of field is critical, we might plan to keep some spherical aberration residual. So we may use a neutral spherical aberration IOL or a non-aspheric IOL. If there is a likelihood of IOL decentration, it's better we do not use a negative spherical aberration aspheric IOL. We should use a neutral spherical aberration aspheric IOL. After a keratorefractive procedure, the spherical aberration changes. In myopic correct, if there is a myopic correction with the corneal refractive correction, there is an increase in the spherical aberration, and in a subsequent cataract development and a post-LASIK cataract situation, we should use a negative spherical aberration IOL. Whereas for a hyperopic correction, in the LASIK correction, there is a decrease in the spherical aberration, and we should use a neutral spherical aberration or a non-aspheric IOL. We can also fine-tune IOL power based on assay. We can judge preoperatively the expected residual assay according to the IOL we are using. And if the expected residual spherical aberration is 0, the target refraction should be plano. If it is positive, then the target refraction should be reduced by 0.25 diopter for every residual spherical aberration of 0.10 micron. And if it is negative, then refractive aberration, the target refraction should be increased in steps of 0.25 diopter sphere for every 0.1 micron spherical aberration. Coming to posterior corneal astigmatism, the posterior corneal surface is steeper in the horizontal meridian, and thus being concave, the effect on the total refractive power of the cornea is the reverse. Thus, it contributes to or adds to the against the rule astigmatism. It has been seen that with higher degrees of anterior with the rule astigmatism, contribution of the posterior corneal ATR is higher, and corneal tomographers have the potential to give us the relevant information for the posterior cornea. Coming to determining corneal power for IOL power calculation, as a rule, corneal topographers should not be used to derive the K value for IOL power calculation. The nearest correlate to manual keratometry values, which are still considered to be the gold standard for IOL power calculation, are the SIM-K values on the topographer or the tomographer. However, in certain situations, corneal topographers do help us in obtaining the K value for IOL power calculation. Like in this specific situation is following a keratorefractive surgery. So if it's a post-RK situation, we can use the numerical view of the Atlas device from Zeiss, and we take the K value as the average of the foldings. Whereas in the post-LASIK situation, particularly post-myopic LASIK, we can use the EKR, the equivalent K reading, and this is used with the Holiday 2 or another third generation formula with double K correction. So what are the take-home messages? The manual keratometry is the gold standard for K value for routine IOL power calculation. Corneal topography tomography helps us in detecting and excluding irregular corneas when lifestyle IOLs, the presbyopia correcting IOLs are being considered. Corneal topography tomography may help us to plan incisions to reduce astigmatism, and corneal topography or tomography may help us in correcting for posterior corneal astigmatism. Thank you for your patient hearing.
Thanks a lot, Dr. Sayan. And this is Mr. Ashok from Microvision. So they would like to present a 1-minute video about their products. Thank you, Microvision, for sponsoring this whole webinar tonight.
Right,
Can
sir.
you have? Yeah.
Yes, sir. Thank you, sir. I'll just play the video, sir. Just a minute.
I would request Dr. Arulmodi Varman to get ready with his talk. His next presentation is on ultrasound biometry. Arul, sir.
The drug trehalose is not only a lubricating agent, but it is also known to have antiviral properties against viruses like the Zika virus and the human immunodeficiency virus. Trehalose is also known to augment the induction of the interferons. The potential role of trehalose for ocular prophylaxis against the COVID-19 has been explained in this review article. The coronavirus binds to the ACE2 receptors on the corneal epithelium. It undergoes clathrin-mediated endocytosis followed by cathepsin-mediated degradation of lysosomal proteins, facilitating the viral RNA release. This is followed by the translation of the virus. This viral progeny are finally transported by the Golgi vesicles to the cell membrane and are exocytosed into the extracellular space. Trehalose blocks cathepsin, degrades endosomes, and augments the induction of the interferons, thus inhibiting the coronavirus.
So, Dr. Arun, sir, can you have your presentation uploaded?
Yes, I'm ready. I'm going to share my screen.
Sir, I have one question for Dr. Sayan.
Yeah. Dr. Sayan, please. Yeah.
Yes, of all the topographs and the tomographs, there is one more value which comes out, which is the RMS value, the root mean square, which gives the average of all the higher order aberrations. How much would that help us in, especially when we are planning to put multifocal IOL?
Yes,
or
sir.
post-refractive surgery patients?
The barometers give us two values basically. It gives us the total RMS value and the higher order RMS value.
Yes.
Now, what we take as a guideline is if the higher order RMS value is more than 0.3 microns, we take it as that the patient has aberrations beyond the normal limits, and it cannot usually be corrected by the regular refractive means.
Okay.
In the
So
refractive practice, we use this wavefront guided ablations for patients having HO-RMS more than 0.3 microns.
So we should try and avoid multifocal IOLs or something like that?
Should be a guideline.
So can I just make a quick comment here? Arun,
Yes,
sir?
yes, please.
Yeah, I would just like to add a point to what San has just told. I think RMS values are important, but apart from the RMS values, if you can actually go down to the microscopic sections of the higher order aberrations, is the third and the fourth generation aberrations which are more important. Even if the RMS values show more than 0.3 or 0.4, and the third and the fourth generation in exact, the trefoil and coma levels are within 0.2 or 0.3, you can still go ahead with ATIL implantations. The first and the second order aberrations are not that important in making a final outcome.
Okay, so we'll get on with the next topic. Dr. Arun, sir.
Thank you, Arup, for inviting me to be here. My talk is going to be on ultrasound biometry, probably the oldest instrument that we use to calculate IOL power next to the keratometer. It still finds its use today in spite of having excellent optical biometers. When we are faced with an absolutely mature cataract, though pleasantly surprising is the fact that the swept source optical biometers can read through an almost mature cataract, or sometimes what looks mature, we still have to fall back on ultrasound biometry. So it's not something that's given up or can be condemned. Okay. So the ultrasound biometer measures the axial length of the eye, the AC depth, and lens thickness. It uses the ultrasound to make measurements. It works on the 10,000 megahertz. The probe injects a thin sound beam, which goes as a thin beam 10,000 megahertz has got minimal penetration, but very high accuracy. Whatever sound that is reflected back from the reflecting surfaces, whenever there is a difference in the sound transmission from one media to another, some amount of sound is reflected back, and this reflection is read off as spikes. And by measuring the spikes that come back as reflections, we can measure the distances that are there. So we can measure the anterior chamber depth, the lens thickness, and the axial length. So measurement on this, the A scan is from the anterior corneal surface right up to the internal limiting membrane. That's the one that has the highest reflectivity on the retina. Accuracy of the axial length is very high with the ultrasound. If done properly, the repeatability is well within 0.1 millimeters, which is brilliant. The ideal scan should have the initial corneal spikes. If it's done on the immersion method, you can actually see a twin spike of the cornea. If it's a contact method, it will come out as a single spike there. Then you would see the anterior chamber, then the anterior lens spike, the posterior lens spike, then the ILM or the retinal spike, and then the sclera and the orbital tissues. What is very important that you should look at the quality. The size of the spike should be at least 60% of the total height, and they should be of almost even height. We should not have unevenness, which tells you that the probe is not probably placed very perfectly perpendicular to the ocular tissues. It also tells you the reflectivity is also not too good. So look for an ideal scan every time you do the scan. Ultrasound biometry can be done either by the contact or applanation method or by the immersion method. Though it's normally thought that the immersion method can only give you accuracy, well done contact or applanation method also can give you excellent accuracy in determining the axial length. Contact scan is pretty simple. The cornea is anesthetized and the probe is placed right on the cornea and the measurements are taken. In the immersion scan, you have several different types of shells that are available, which are basically hollow shells that are filled with BSS, placed on the cornea, and the probe is placed in the water bath or the BSS. The probe does not touch the cornea, thereby removing one source of error, which is the indentation of the cornea. That's about all that the immersion device removes, the source of error that comes off from indentation of the cornea. So theoretically and practically, it's more accurate than the applanation method. The immersion scan, you would see a slight double peak on the cornea because the probe doesn't touch the cornea. You can see a double peak. Then you would see the anterior lens, the posterior lens, and the peak otherwise are the same. The limitation of the immersion method would be that it is kind of time consuming and messy, requires the patient to be supine, and improper cleaning can be a causative factor for cross infections to occur between patients. So the shell and the probe should be soaked in alcohol or hydrogen peroxide or bleach and cleaned properly. Okay. For accurate A scan, we have to do the scan in the lying down position. And never with the patient sitting down, even in the contact method. Patient positioning is very important. When you place the position, position the patient, the head should be flat. It should not be bent as you see in here. You should have it placed absolutely flat so that you can get the iris plane parallel to the floor. So you should be very sure that the iris plane is parallel to the floor and the probe should be perpendicular to the iris plane. The corneal beam should be parallel to the visual axis so that the echoes are received properly to the probe and it is not tilted. Fixation is very important. You want the patient to fixate on some object so that the eyes are looking straight. A very simple device would be to tell the patient to lift his or her hand and focus on it. Even in a patient with a mature cataract, the proprioceptive impulses coming off from the limbs and the finger can help the patient focus accurately at the finger, even though the visibility is poor. Or you can have an overhead fixation target where your light, you can have a laser pointer shone on the roof or the ceiling, and that can be used as a fixation. There's a fixation light that's available on the probe, which also is very useful for you to fixate. The positioning, as we told you, should be in a way that you can use the hand fixation or the fixation light of the probe. Remember to wet the probe and place it very gently so that you have a proper wet surface without having to press on the cornea. Place just the same lubricating drops, or better still, the lignocaine drops that you're using to anesthetize the cornea. Hold the probe with the wire so that you would not be pressing down or putting any pressure on the cornea. This way, the probe can just be made to touch the cornea very gently, very, very lightly, so that the indentation will not occur. So you can get the readings more accurately this way. You can see here, whenever you get the readings, please look at the spikes. They should be almost of the same height. Look at the axial length. Do look at the AC every time, and the lens thickness. Don't just look at only the axial length. Here you're holding the probe. Here the probe can cause compression on the cornea when you hold it with your fingers. Even the light pressure can compress the cornea, and the readings can go slightly haywire. That's why it's better to hold the probe with the wire. So you can see here that the axial length is off by 0.1. The AC depth, you can see, is very different between one reading here and the other one there. And the spike also shows a drop. While here, the spike is almost at the same level. So this quality of the spikes is not good, as well as you cause indentation. So this reading should be discarded. We can have different settings. One would be whether you're doing the whole recording on the automated mode or the manual mode. Automated mode has got its own gate settings. If the spikes go up to the gate setting, which is considered good enough by the auto mode, it would accept that and record it. Whenever you have difficulties, you can go on to the manual mode, where you'll have to look very, very diligently on the spikes and push down on the foot pedal to freeze. Whenever you think the spikes that you're getting or the image that you're getting on the screen is suitable or of a good quality. So it's good to go with the auto when all the readings are very easily coming off. Any difficulty, it would be nice to get onto the manual mode and do that recording. Gain settings would be to get different levels of gain when you need it. Increased gain would be required when the height of the echoes is inadequate. This occurs most often in a very, very dense cataract where the sound transmission drops and you need to increase the gain. From a normal standard setting would be somewhere between 50 to 60%. You might have to go to 80, 90, even 100%. Decrease in gain is required when there are artifacts near the retinal echoes, which you would see typically in pseudophakic eyes or silicon oil-filled eyes. Please remember, if you were to consistently send a very high gain, you could be getting shorter than normal readings, and very low gains, you could end up getting longer than normal readings. So make sure that the gain is set in such a way that the spikes that you get on the screen are sufficient and are of good quality. Sound velocities are different for different types of eyes, a phakic eye or a phakic eye or a pseudophakic eye. Remember to set those settings. Please take multiple readings. Check every waveform on the A-scan. Do not take averaging. It's very important you just don't blindly average. Choose the best and consistent waveforms. Remove the inconsistent and poor waveforms. And after that, you can still, if you want to average, yes, you can go average it. You're better off taking the probably 3 to 5 good waveform readings and then averaging it. But you have to be very sure that these axial lengths should be very close to each other before you average them. Don't take outliers and average them. So we find here that this is of a good quality image here, while this is a poor quality here. So you should not take these images which are inconsistent, while you should have proper spikes before you accept that. Ensure that every step is accurate. You can see here that the image, the anterior lens spike is much shorter than the posterior. This signifies that the probe is not perfectly perpendicular to the iris plane, and you're getting grossly wrong readings. So remember that. Look at all of these readings, including the K readings, before you do your final calculation. Because a slight error in the K reading, another error with the axial length, another error with the A constant could have a stacking effect and can give you really bad results in the end. So look at not only the axial lengths, look at the K readings also, look at the axial length, look at the AC depth and the lens thickness each time and the spikes. So pearls for accuracy in ultrasound A scan would be calibrate the instrument. These instruments come with calibration blocks. Once in a while, do calibrate to make sure that the instrument is properly calibrated. Immersion or contact method with the patient supine. Iris should be parallel to the floor, most important. The probe should be perpendicular to the iris plane. Patient fixation is very, very, very important. Check waveforms for all scans. Don't just take the numbers. Check AC depth to avoid inadvertent corneal compression. Hold probe by wire when doing the contact method. Don't hold the probe directly. Do not average readings. Take the best readings by choosing the best waveforms. In special scenarios, posterior cephaloma is going to be a bugbear. Both very long eyes and very short eyes are problems with ultrasound biometry. You're trying to do the ultrasound biometry and you're hoping to find out the length of the eye along the optical axis when it's not very sure that you're getting the optical axis length every time. You're only getting the, you're getting the length of the eye, but may not be in the visual axis. Especially in staphylomas, you're not sure whether the macula is at the depth of the staphylloma or on the slope of the staphylloma or at the edge of the staphylloma. One that can help you would be to do a A plus B scan, and then this can help you get more accurate results. In very short eyes, you have issues. Macular lesions, shallow retinal detachments, macular edema, or a tumor of the retina can give you false readings. So you see here that there's elevated macular lesion, but here the spike is visible, that you get a double spike. So when you see these kind of erroneous spikes, make sure that you're doing a B scan before you accept these readings. Dense cataracts would cause low spikes, so we'll have to increase the gain. So one of the issues is the dense cataract in A scans with ultrasound. But again, in a very dense cataract or mature cataract, often the optical biometer fails you and you have to come back to the ultrasound biometer. So learn the technique of doing A scan properly, because this is going to serve you in a very difficult situation. Silicon oil filled eyes, check out what kind of silicon oil was put in, 5,000 or 10,000 centistokes or higher than that. Each one of these has got a different velocity of propagation of sound. So that has to be entered in to get accurate values. Pseudophakic eyes, if you're ever going to do them, please check if the lens is PMMA, silicon, acrylic, hydrophilic, and check out, and you'll have to enter appropriate correction factors. Drawbacks, most important drawbacks is that the ultrasound measures the anatomic axial length, where you hope that it coincides with the optical axial length. Often it doesn't. So that's one issue. Posterior staphylloma, as I told you earlier, in both extremes, long eyes and short eyes, even small variabilities of the axial length can give you high variability in the postoperative refractive outcome. Of course, we all know that the ultrasound measures only up to the internal limiting membrane. Of course, all the formula are giving in a correction factor automatically for this, and you have to enter in a different A constant when you're doing optical biometry. So limitation of ultrasound A scan would be in very long eyes and short eyes, it's going to be difficult. You are better off probably using the optical biometer. In posterior staphylloma, optical biometers are better, but of course you can use A plus B. Most important fact is it needs an experienced operator. You can delegate an optical biometry to almost anybody, but you need an experienced operator when you are doing an ultrasound A scan. Dense cataract gives you a challenge, but often you'll have to fall back only on this. Pseudo also are a challenge. So erroneous short measurements, corneal inundation, low sound velocity, too high a gain, malalignment of probe, most important. I cannot overemphasize that the probe should be perfectly perpendicular to the iris plane. Erroneous long measurements, if you're doing immersion and there is bubbles in the fluid bath, then you will get erroneous long measurements. The sound velocity has been wrongly entered, too low gain, posterior staphyloma, or a very thick lens. So errors, particularly if the eye is going to be very long or very short, even small errors of axial length measurement can give you great refractive surprises. Keep that in mind. Can A scan give you precise results? Yes, it can. If it is done properly, you can get perfect results day in and day out if you apply your mind and you apply the right technique. That you can use this even for the multifocal lenses to be well within 0.5 plus or minus spherical refractive outcomes, so that your multifocal results are very good. A scan means you need to have good technical skills to get good results. It is definitely doable. It is not a difficult issue. Thank you.
Thanks a lot, Dr. Arul. It was very nice. And as the next speaker, Dr. Mishra, comes on the screen, we'll take some questions for Dr. Arul. Anybody, Nazdin, you have any question for him?
Arup, I just wanted to make one point. Now, most of us are using optical biometers, but sometimes we
Anurag, can you share this?
Mature cataract. Yeah. So sometimes we encounter a mature cataract in the biometrists. They just use the ultrasound and then they enter the axial length into the IOL Master 700 and do the calculation, where you can get an error because basically the ultrasound biometer measures up to the internal limiting membrane, whereas the A scan of the IOL Master 700 is up to the RP. And because of this, you cannot really use the same A constant. So if you're putting in the value of the axial length from the ultrasound biometer, then you have to change the A constant when you're doing the calculation. So that's just a point I wanted to make.
That is a very important point, Sri Ganesh.
And just one more point is, all these A scans, they assume the retinal thickness to be 200 microns, and the actual retinal thickness can, it can vary, be from 160 to 400 microns. So I think the optical one scores on that point.
Exactly, in terms of accuracy, definitely. Yes. So Dr. Anurag Mishra, can you just have your on the board?
Is my slide visible, sir?
Yeah, we can see.
Right. Thank you so much, sir. Good evening, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. Gratitude, Arup sir, AIOS, for the platform, and Arul sir in particular for giving me a cue. We are going to pick up from where you left, sir. I do work with the industry, ladies and gentlemen, but none of that has got any influence or any bias in this talk in particular. The ultrasonic biometer has done a pretty reasonable job for all of us, but there were a few aspects which needed special emphasis. We did falter on the issue of accuracy. We wanted to measure more number of parameters and wanted to measure them accurately to essentially predict the elusive ELP, which were required for the modern day formula. So the answer was technology giving us optical biometers, and they work on different technologies. Let's just peep into them before we proceed further. The first optical biometer that was launched into the market worked on the principle of partial coherence interferometry that was incorporated into the IOL Master and then on the IOL Master 500. It utilized a light source which was multimodal. It has a flickering wavelength, the max reaching up to 780 nanometers. When it comes from the light source, it gets differentiated by a beam splitter into a moving and a split mirror. Both the light beams enter the eye. Both the light beams get reflected by another fixed mirror to be caught by an interferometer. The waves come into phase at a certain given point in time where they're coaxed and produce what is known as a constructive interference. Now, apart from this, the IOL Master 500 also had an interesting concept built into it. These are the wave patterns that are produced by an optical media which is opaque, very bizarre. So what it did was it differentiated between signal, which was generated by the eye, and noise, which was generated by the optical media, which was opaque, and also the machine due to irregular refraction of light. It escalated the signal, accepted the signal, discarded the noise, producing a higher signal to noise ratio, and then produce a uniform curve with a single peak. We would get a clearer picture in this GIF. Just keep an eye on the right-hand side column out here. When we start measuring and the number of measurements increase from 0 to 20, the bizarre waveforms give rise to a single rising in height Manhattan, and the signal to noise ratio also is increasing to pretty much acceptable levels. The IOLMaster 500 gave us different readings in terms of keratometry. The axiometry was pretty much accurate, coming into within 100 microns of accuracy, but the keratometry was little faulty. The anterior chamber depth was based on slit beam reflectometry and not really a proper measurement. The white to white also had a little aspect to be desired. To correct all these, the next technology was launched, which was the optical low coherence reflectometry used by the Hagstrite Lenstar LS900. It produces a light wave. It's produced by a light wave which is 820 nanometers in wavelength. So expectedly, the penetration would have been better. The light wave that enters the eye and gets reflected back is compared with a reference optical beam that is already incorporated in the machine. This reference optical beam undergoes a Fourier transformation, and then both the light beams that coming from the eye and the reference are matched with. They produce a uniform A scan right from the cornea to the retina. So almost any point to any point can be measured. It gives us the lens thickness, the anterior chamber depth, and the light source that is there is the superluminescent diode, which has a constant spectrum in contrast to the flickering frequency of the IOLMaster 500. But there were features that were faulty with this technology as well. This did not have the composite signal technology as the IOLMaster 500 had, so it had difficulty in penetrating, particularly a dense sheet of posterior subcapsular cataract. To address to all that, the final technology was launched, which was the step source OCT. It utilizes a light source which has a wavelength mean of 1060, but the wavelength sweeps across 1050 to 1070. That's from where it derives its name of step source, actually, with the mean being at 1060. It has a single fixed mirror. Both the light rays again enter the eye and get reflected back into a photodetector device. The IOLMaster 700, which utilizes this SSOCT principle, gives us a continuous B-scan image like this right from the cornea till the foveal pit. It scans the eye in 6 radial meridians lined at 0, 30, 60, 90, 120, and 150. 128 scans are taken along each of these meridians, and the whole measurement is repeated 5 times. So that's amounts to 2,000 scans per second. It gives us a very accurate anterior chamber depth. In fact, it also gives us an AQD, which is the distance between the endothelium of the cornea and the anterior lens capsule. Comes in very handy when we are planning a phakic IOL. It gives us an axial length. It gives us the central corneal thickness, pachymetry, and it also gives us the lens thickness. So all these measurements are possible with the SSOCT. What is also possible is that we can see from where the measurement has been taken. If we can see a foveal pit clearly, then the measurement is to be taken. If we cannot see the foveal pit clearly, then the measurement should be discarded. So for the measurements to be accepted, we have to have the subsequent measurements, and the measurements should yield an axiometry within 30 microns of standard deviation. The keratometry should yield values within 0.05D. Fixation and tracking should be proper and should have an echo-free vitreous. Now let's go to my clinical biometry workflow. I have 4 workstations for the patient to travel from one station to the other. This starts with the IOLMaster 700. As we talked about, it produces 2,000 scans per second. It penetrates the dense cataracts because it has a 1,060 nanometers light source. The measurements are all telecentric because telecentric, the advantage is if the machine does take a reading, if the machine doesn't take a reading, it's different. But if the machine does take a reading, it's not dependent on the distance between the eye and the machine's eyepiece or objective lens. So if the machine takes a reading, then it is usually accurate irrespective of the distance. So that negates some sort of user influence. It gives us the opportunity to do a fixation check. And there is an inbuilt algorithm for silicone oil filled eyes and post laser vision correction, as we would see in a moment. The next station the patients have to go to is an eye trace, which has a proprietary ray tracing technology. It gives us both wave front and sim case. The higher order aberrations, angle kappa and alpha, the offshoot axis are calculated accurately. Pupillometry in all circumstances can be calculated. It gives us a tracy refraction, which is very interesting. This is a refraction which is calculated at the pupillary plane or at the anterior lens capsule plane. So even if you don't measure the posterior cornea, you can get a fair bit of idea of its contribution to the manifest astigmatism. It gives us a modulation transfer function curve based on the reading of which we can decide whether the contrast sensitivity is already reduced and whether the candidate is a good candidate to receive a multifocal implant. And finally, there's an Osher's alignment check should you go wrong with a toric implant. You can always go and cross-check that in the post-operative period. The next workstation in my setup is the image-guided variant system. It gives us a keratometry based on 12 LED lights arranged in a single ring, but there's a certain amount of dynamism that is associated with this keratometry. Before the instrument comes to a focus, the 3 infrared lights actually map the corneal curvature as well. So it gives us very dynamic keratometry. It has an excellent planning cockpit in terms of the exact residual refraction that the patient is likely to land up with after the cataract surgery is done. It can enable you to give an on-axis incision. I'm an on-axis surgeon myself. And of course, the system is markerless. And finally, combining all these platforms, the new warrior that has descended on the Western Front is the Heidelberg Engineering's equipment called Anterion, which the patient has to go through in my setup for the final testing. It combines both stress source OCT and ray tracing technologies. It is a tomographer, however, you can take in the central corneal readings as well. 16,000 data points are analyzed before giving you the keratometry in this case, and all those are OCT pieces. So they claim that it is independent of the integrity of tear film, and we have more than one observations to prove this claim as well. But it does give you a blinker on the side of the screen that the tear film is not integral. So I'm not saying that you shouldn't treat the ocular surface condition, but at least it is independent of the integrity of the tear film. It has the best penetration in the form of the light source, which has 1300 nanometers of wavelength, and it gives excellent high definition imagery of the anterior segment, as we'll see in a while. Coming to the measurements, when it comes to the keratometry, I always take the anterior readings. Most of these equipments are in agreement with each other for most of the patients, but should there be a disagreement for the keratometry, the order for me is always anterior followed by variant, and then finally IOL Master 700 and eye trace. For the axiometry, it is anterior and IOL Master. Both of them perform reasonably well and quite equitable. For the higher order aberrations, the eye trace, of course, is one of the best equipments in the world. The anterior also does a pretty reasonable job with that. And for the offshoot of axis, the measurements are given by the measurements are given by eye trace in terms of value and a vector. The anterior also gives us a measurement of the same, but the variant and the IOL Master, they give sometimes give faulty ratings. The variant, in fact, gives you just markers from where you can get a fair bit of idea, but it doesn't give you any measurement at all. So let's look at certain clinical applications. This is one example wherein the difference between two subsequent measurements is 10 microns in terms of axial length and 0.02 diopters in keratometry. So this is one reading which you can accept vis-a-vis the next reading wherein it shows 190 microns difference in the axiometry and 0.5 diopters difference in keratometry. This sort of reading should be discarded. This is one example wherein I had missed something clinically. My optometrist came running to me and said, I find something in the B-scan image of the IOL Master 700. Please cross-check. We did an OCT and found that there was an ERM pulling on the macula. I had missed it clinically. Call it my negligence, but I had missed it. There's another clinical miss by me in one of the other patients, which the optometrist brought to my notice and showed this. We did an OCT and found similar pictures in the OCT at the macula. This patient should have landed up in disastrous outcomes post-operatively if had we missed these findings brought to my notice by the enigma of the posterior polar cataract. It's a central, densely sitting plaque, so the light rays often do not penetrate through it. But the anterions, this is the anterion reading. The anterion's excellent wavelength actually does that and gives us all the readings that we require from the machine. And it also gives us an anterior segment picture like this, where you can see the plaque and you cannot see a broad daylight passing through between the plaque and the posterior capsule. So these are instances where the posterior capsule is likely to be involved in the plaque, so you should be very careful while handling them in the OT. The lens tilt sometimes corrects the toricity of the cornea, sometimes augments the toricity of the cornea. This should be found out. This is an IOL Master 700 picture, and you can see the tilt here, but the fixation check will tell you that the fixation has been proper. So this tilt that is shown in the B-scan image has not been due to a fixation lost by the patient. We can know that. So there is a lens tilt. The other method to find it out also comes from the anterior. As we can see, the light passing through the corneal vortex is shaded green, but the lens axis is shaded yellow, which is based on the lens vault. So they are not in agreement out here. So they vary from each other. The lens tilt can also be found out with the eye trace. This was one patient wherein we had attempted, or the variant showed us a T2 to be implanted in this patient, but when we subjected the patient to eye trace reading, as you can see on the internal plane, all the higher order aberrations are grossly elevated. The cornea is doing fine, but the internal plane, all the higher order aberrations are elevated. This happens when there is a lens tilt. So we went back and decided against putting in a toric implant in this particular case. This is a case wherein there was a hypermature Morgagnian cataract, and you can see the OCT imagery of the anterior, which is very clear. It has taken the whole lens slice. The lens thickness is grossly increased to 4.53 millimeters. So if you're planning a femto in this particular patient, we have to make sure we have to mentally imagine that the nucleotomy at least is not going to travel till the posterior plate. So we have to manually fracture it inside the OT.
Anurag, I think we have to keep an eye on the time.
Yes, sir.
Okay.
This is my last slide.
Yeah.
This is my last slide. So the silicone oil filled eye also has, this is a vitreous body. Keep an eye on the IOL power calculated is plus 19, but when you switch over to silicone oil mode with the same machine, if you just switch over to the silicone oil mode, the machine auto calculates this, and plus 22 is the the diopter that comes in, which is pretty equitable with the other eye, which also shows a plus 22 for the same IOL. So the silicone oil mode and the post laser vision correction mode are also incorporated in the 700, which give us accurate readings in these circumstances. Thank you so much, ladies and gentlemen, for the kind attention. Thank you for the opportunity.
Thank you, Anurag. And we'll request Dr. Hanbor Pham, can you put up your slides in the share screen? And it was a good presentation, Anurag. We learned a lot, saw a great deal about complex post-apolar cataracts and intravision cataracts. So we'll have the questions for the end, and we are noting down what are the questions that have to be taken care of. And Hanbor Pham, are you ready with your slides? Yeah.
Yep. Can you see my slide?
Yes. Yes.
Okay. Am I to go now?
Yeah, please. Stage is yours.
Okay. So I'm just going to talk about overview. In fact, this is actually a comparison of most of the current IOL power calculation formulae. Sorry. Oh, okay, this is my financial disclosure. Well, first we're going to look at a single IOL. These are mainly ZXCB. If you look at most of the publication, they are mainly Equisoft platform. This is 381 eyes. Okay, this is a box plot. What we are interested in is the 4 quartiles. Usually the outliers may be problems due to other than formula, but what we are more interested in, these are all optimized. That means the mean prediction error, which is the actual post-op refraction minus the predicted refraction. The mean of all the eyes should be 0, but we are looking at the quartiles, so the median prediction error should be close to 0 unless it is severely skewed. Okay, so you can see here most of the formulas here, the median prediction error is close to 0 except SRK2. The other thing we are more interested in is the compactness of the 2 central quartiles. If this is something like standard deviation, if it's compact, I mean, it is very well, standard deviation is very low. If it's widespread like in SRK2, I mean, it is not very predictable. What we are interested here, you can see is the RBF, Barrett, and EVO is quite outstanding. High gaze is also not too bad. But for this kind of single IOL across all eyes, because most of the eyes are within normal range, you can expect most of the formula to do relatively well. This is the absolute error. Absolute error is a prediction error, but disregarding the sign, whether it's positive or negative, we take them as the same. And then again, this is the box plot. We have the median absolute error, which is something that we are usually interested in. This is also a measure of spread and how far it is from the mean prediction error. The closer the box, the better. Again here, RBF, Barrett, and EVO. These three boxes here is quite good. High-gaze ULIP, high-gaze personally triple optimized is also very good. This is the percentage error, percentage of prediction error. In the past, we look at 1 diopters. Today, we should be looking at half a diopter because the formula has improved so much. So what we are looking here, we're looking here, you can see RBF Barrett high gaze are over 80%, together with EVO over 80%. The FT1 and FT2 are my own excellent adjusted, published in BGO 208. These are now superseded by most of the newer formula, but it's doing not too bad here. But what is clear is this is time to totally discard SRK2 because it is absolutely hopeless, and don't ever use SRK2 anymore, at least message from here. What about the other data out there, the publication there? This is one publication by Cook, over 1,000 eyes, compare PCI as well as OLCR eyes for him, and say that the Barrett high gaze and T2 do very well here. And for the OLCR, which is the lens star, the Olsen, Barrett, and Olsen do very well here. Plus minus half a diopter is over 80% or close to 80%. Okay. Now, there's other publication by Kane, one by Kane in 2017, and another one by Savini in 2019. For Kane, we found that the Barrett was very good here, over 80%. RBF is close to 80%, T2 is close to 80%, Holiday 1 is close to 80%. Savini was using a different strap source biometers, and he have gotten very good outcome. For him, his EVO, RBF, and Kane were the top 3, hitting 90% with this 3 formula, while Barrett is close to 90%, Barrett and T2. Mellors has the most eyes, published in 2018, and he has recalculated and some updates in 2019. So we just look at the 2019, was 2019 close to 80% of Kane's, Olsen, Barrett, and EVO, and here RBF as well. So you can see it's consistently, these new formulas are doing better than some of the older traditional formulae. The latest is by Cheng. This is just published in, I think, the latest issue of JCRS. Of this group, they have very good outcome from Kane, Olsen, Barrett, EVO, and RBF. They're all close to 80%, way above the 70%. This is 410 eyes using strap source OCT. What is interesting from our data is that this is the traditional formula, and this is the newer formula together with high gaze. You can see the traditional formula that's sensitive to axial lines. There's a correlate, there's a regression against axial length that's inclined. So if you are long axial length or short axial length, you end up either on under predicted or over predicted. Look at the newer formula and the high gaze triple optimized, they are neutral to axial length. This is important because otherwise you start to have errors at the extreme of axial length. What about K? This is based on keratometry, the traditional formula. You can see it's again SRKT and high gaze as well. There's high gaze is here. They're sensitive to K. That means the varies with K, their predictability. Hofferkills and Holiday are less sensitive to K. And again, the newer formulae, they are less like Barrett, EVO, and RBF. They are kind of neutral to K. This is corroborated by data from Malays. The newer formulas are less sensitive or neutral to X-length and K, while the traditional formula, some of them are very sensitive to K and X-length. And that is one reason why the older formula, the traditional formula, don't work so well in today's refractive cataract surgery scene. Well, I'm going to look at short eyes. We don't have that many short eyes. It's less than 22 mm, 37 eyes. Here, our data show that from this exhibit show that the Hoffer-Q, Holiday 1, and SRKT tend to end up over predicting with the patient end up with myopia. For this group, RBF is good, Barrett is very good, Evo is also good, high gaze is not too bad. They predict, I said, this is using the same optimized constant from the general population. The percentage of eye within half diopters, RBF, Barrett's, triple optimized or personal triple optimized are all very good. Evo is not too bad. But in our data, surprisingly, Hoffer-Q and Holiday 1 doesn't do too well. Well, we'll compare with Cook's eye. Cook ranked them in his data set. Barrett, T2, and Haggis do very well for PCI, and for OLCR, Olsen, Barrett did very well. So it's slightly different, but there's some consistent formula that do relatively well in most of the data set. Goxe did a study mainly just for short eyes, and we look at the compactness. This is absolute error, the median absolute error, and the compactness for, in his case, Barrett, Haggis, RBF, and Holiday 1 is very good. Olsen doesn't seem to do so well here. This is pre-optimized, and this is post-optimized, so it looks about the same. Well, Kane study early on, they also have, look at the short eye segment, and Cheng as well. For these two, they just highlight the better performing formulae. In Kane's case, the Barrett, Holiday 1, RBF is good. In Cheng's case, Hoffer-Q is doing very well with the new Pearl DGS from Damien Gatinel group is also doing very well. Surprisingly, Kane doesn't do so well, and RBF doesn't perform so well here. What about long eyes? This is 154 eyes. We just look at the long eyes, anything that's beyond 26 millimeter. Well, most formulas tend to end up on the hyperopic side. I mean, the formula under-calculated, giving the calculating the power that is too low, and the patient end up hyperopic. This is using the same population-based optimization. RBF is slightly on the hyperopic side, but it's not too bad. It's quite compact. Barrett is good. I guess it's actually quite good. Evo here is actually very good, and more or less in the center. How about within half adapters? Within half adapters, the first four formula, which is RBF, Barrett, Haggis, the two Haggis stand tall above the rest. Evo is the best performing in this area. We look at the Cook data set. Cook data set shows that Olsen, Haggis, and T2 is a better performing one for IOL master, and for Lenstar, Olsen, and Haggis are the better performing, formulae here. Keynes has better performing with a Barrett and Holiday. This is a 2017 paper. The rest of the formulas, here, RBF is not too bad. For the really long eye, then the Barrett Universal 2 seems to do the best, followed by Hill RBF. Cheng's the most recent paper shows Kane is the best performing for medium long eye, followed by RBF and Barrett. Actually, all of them perform very well. For longer eye, more than 26, then Barrett, Kane, and Evo performs better than the rest. Now we go to the very extreme. These are the 5 diopters or less, and or the negative territory. I think they're 40 over eyes or 50 over eyes. I can't remember. This is my own data. Of course, you can optimize them for just this segment of the population. And with a conventional formula, you get quite good outcome, but they still end up on the hyperopic side. But to do that, you will have very extreme constants, like in this case, 107, 101. This is not normal, and this is not easily accessible. So what we do is we use what is the A constant on the box, because you can't, these are sometimes different IOLs that they don't have normal power range. And with this, using the constant from the box, you can see here, Barrett and Evo were outstanding. Most of the other formula, these are out of domain, so they won't give you a prediction. So we just work with Barrett and Evo here. And based on ULIP against Barrett and Evos are almost spot on with very tight, very low standard deviation. When we look at plus minus half a diopter, the percentage of eyes, again, this is inaccessible, so let's ignore this. This is based on the box. Manufacturer suggested A constant, and this is based on ULIP. There are only 2 formulas stand out within half a diopters. Only Evo and Barrett are above 70%. The rest of the formula within half a diopters are less than 50%, except for eye gaze, which is slightly higher. For holidays, yeah, eye gaze, which is slightly higher. So in this territory, most of the traditional formula does not perform well. You have to go on to the newer formulas such as Barrett or Evo, and hopefully the other formulas will come on board as well. So if you look at all these, the evolutions of a formula, this is the most important slide. This is quite similar to the one published in the editorial by Doug Cook. When in the past we used 19 diopters, we have a lot of refractive surprises. Then along come ultrasound biometry. And then at that time, we have the simple regression, which is the SRK and SRK2. These are data-driven formulae. Then there's a simple thin length versions formula, such as the Binghorst, the Holiday one, the Hoffer-Q, the SRKT, and then the modified SRKT, such as T2, and so on and on. Then optical biometry comes along. Now measurement get more accurate. We can expect better formulas to come along. The second thing is, of course, computational power. In the past, these are all done with pocket calculator. Today, we have computer with processing power that's so good. It takes manually something that takes a week to calculate today. This takes just a matter of mere seconds. So we can have better formulas as well. Holiday tools, okay, and then high gaze, which is mainly based on optical biometry. Of course, subsequently there's ray tracing, iterative thick lens version. These are based on computational power as well as thick lens. They need a computer to iterate the power. And of course, artificial intelligence, such as the Hill RBF, and of course, the combinations of optical as well as artificial intelligence. The reality is that the line between all these formulas, all these modern formulas are not distinct, because there's quite a bit of overlap between optics as well as artificial intelligence as well. What is clear is a simple regression formula should not be used at all now. And the simple thin lens versions is obviously on its way out. All right, if you have optical biometry, if you don't have the formulas integrated in your biometers, you can go online. You can use the RBF, the Evo, the Barrett, as well as the Kane online. course, you can also, some of these formulas are integrated, such as ozone phaco optics with a topographer or tomographer and oculics as well. So with that, thank you very much. I'm done.
Thanks a lot, Hanbor Fam. I will just have the questions a little while from now. Can I request Dr. Dao, to have your screens, slides on the screen with the share screen approach. So before Dao starts off, I have a question for Hanbor Fam. If many of us use immersion ultrasonic biometer, and can these formulas, the recent formulas, be used when you have got the data generated using immersion A-scan biometer?
I think that's a very good question. We haven't actually looked at this deeply. What we do know is that the Barrett and EVO, because we have good access to these two formulas, works quite well with ultrasound, with a bit of a change of a constant.
A constant, yeah.
High gaze does not work well with ultrasound unless you completely change the triple constant. A simple single constant high gaze usually don't work very well with ultrasound. So that's my take on this.
Okay, so thanks a lot. We'll have questions reserved for the end. And I would invite Dr. Dao Kok, Toric IOL. So you've all been waiting for your talk. Over to you, Dao.
Thanks, Arup. And it's really a pleasure to be with all of you. And I must say, the talks have been absolutely brilliant. And I've learned a lot. And I really congratulate all the speakers for what I think has been a really superb session so far. Okay, let's see if we can get this to go. So what do we know about toric IOL calculations? And because you've heard so many good talks, you're going to hear some repetition compared to what I'm pointing out here. So what's our threshold for correcting astigmatism? I think it depends on the patient's needs, but for a monofocal IOL, it's around a diopter. For a multifocal IOL, however, we need to be within a half diopter or less of accuracy. And the reason for that is we're combining two sources of contrast loss with when we're using premium IOLs. We have, of course, our old friend, the conoid of Sturm for astigmatism, which means that light is not focused at any one given point when there's existing astigmatism. And then we have what I call the cone of multifocality with a multifocal or even an extended depth of focus IOL, where again, the light is not brought to any given one point of focus. So when you combine these two, the conoid of Sturm, and you superimpose the multifocal IOL on it, you can see that the blur circles get larger for any of these various iterations of astigmatism when you have a multifocal IOL combined with astigmatism. So, and this was shown beautifully by one of the many wonderful studies done by Hayashi, where they took the Restore 3-diopter lens and they added a half diopter of astigmatism, and they saw a dramatic drop in vision from 2020 to 2030. So we need the astigmatism less than a half diopter. Now, what about surgically induced astigmatism? It's a lot more complicated than we have thought about. I operate temporally, and with my 2.4 millimeter incision, my mean, that means the centroid on the double angle plot, the mean astigmatism was 1/10 of a diopter. So that's what I use. But there's a lot of scatter in the data, up to 0.8 diopters. And that means either our devices aren't measuring accurately, or truly there are some patients who get an unusual amount of surgically induced astigmatism. And this is only in the anterior cornea. So I use 0.1 as my baseline for my toric calculations. You can calculate your surgically induced astigmatism with many websites, including Warren Hill's here, the SIA calculator. And now we have a way for you to calculate it on the ASCRS, ESCRS, and JCRS websites with a corneal SIA spreadsheet that Adi Abalafia has done. Well, but SIA is more complicated, and a paper from Jack Holliday and George Pettit recently really makes the point that surgically induced astigmatism really is the postoperative refractive astigmatism minus the preoperative corneal astigmatism, whether it's anterior or total. And the SIA includes a lot of unknowns. posterior corneal surgically induced astigmatism, lens tilt, other things. Ultimately, we'd love to know what each one of these is so we can measure each precisely. But right now, we really have this kind of crude or kind of grouped number of post-op refractive astigmatism that includes so many things, and we compare it to the pre-op. And it's interesting that the data that he presented in that really confirmed the accuracy of the original Baylor nomogram that I published. So we've talked about, and we've had great talks in keratometry and topography using 2, maybe 3 data points, the lens star and the IOL master, and now the Anterion for power and meridian primary. But topography is very helpful for alignment. I don't rely on topography as much for the corneal power, but I really rely on topography by using placido-Meyers. I think placido-Meyers are essential in my practice for evaluating the corneal surface because I can detect subtle abnormalities. And interestingly, sometimes the glasses give you clues about the patient's, perhaps it's the lens tilt, because you may see in the prescription of their glasses less with the rule of astigmatism or more against the rule of astigmatism, suggesting there might be some lens tilt. And whenever there are discrepancies in these measurements, I remeasure them. And if they continue to have discrepancies, then I will not correct the astigmatism at the time of surgery. I'll reevaluate with a good refraction after astigmatism. So we've heard about data analysis, and here's a good example. This patient came to me for pre-op, K readings 4334, astigmatism 2 diopters at 174. The IOL Master 700 did not give me any K readings. And you can look at the reflected Meyers from the IOL Master 700, and you can see there's a missing data point right here. And here are sequences of IOL Master 700s, and I finally got 2 measurements with this patient but still without good, here's finally one with a data point there. And then I went back and I looked at the patient's exam 3 months previously. The Galilei said that the mean corneal power is 44.6, but the lens star at the time he presented for surgery was 4334. And the astigmatism that I had gotten with the Galilei was 1/10 of a diopter as opposed to 2 diopters with the lens star. So it shows the amount of error that can be introduced, and these are the Meyers from the LEDs of the lens star, showing the same sources of error in the same consistent area infratemporally as we saw with the IOL Master 700. And when I treated the surface and repeated the measurement 6 days later, everything lined up, all the K readings matched. He did not need a toric IOL. I put an EDOF and he had a great result. So we do need more than one measurement, but as important as that, we really need to verify the quality of our raw data. And we can do it qualitatively by looking at the Meyers, whether it's those Meyers that you have with the IOL Master 700 and the 18 LEDs or the lens star, or as was shown so nicely, even with the IOL Master 500, or you can use your standard deviations. And Warren Hill has shown us, for example, for the lens star, the standard deviation that you want to get is no more than 3.3 diopters for the corneal power, steep or flat meridian, and 3.5 degrees. So how do we factor in posterior corneal astigmatism? Well, we know that posterior corneal astigmatism tends to be steep vertically, and it contributes to against the rule refractive astigmatism. That's in 80% of the eyes. In the other 20% of the eyes, though, the posterior corneal astigmatism is either oblique or actually steep horizontally. So we can incorporate it into our toric calculations by using regression formulas or by directly measuring the posterior corneal surface. The regression formulas, we started with the Baylor nomogram, the Barrett, the Abulafia-Koch, the now J&J, and then the Alcon toric calculator, which is in fact the Barrett. And they're getting about 80% within a half diopter with that. We looked at our data. Let me make the point that Graham Barrett has talked about using 3 values, and Sri Ganesh mentioned that earlier. That's an excellent approach, and he uses the mean of these 3 values. And I think this is particularly useful for people who, as surgeons, may not have a lot of time to study the data, and they want to use a sort of a formula that can be done by their technicians and given them. And Graham did show slight improvement in accuracy with this. My preference, though, is really to pick the best measurement. And by best, I mean I look at the reproducibility and I compare it to other measurements. So I look at each one separately and pick the best one. And with that approach, we've been pretty accurate. So the problem, though, with all of these sort of formulas that don't measure the total corneal power is that there's variation in posterior corneal curvature. This is a map of or a graph of the anterior corneal curvature astigmatism, and in patients with the rule astigmatism, and this is the posterior corneal curvature measured with a Galilei. You can see there's a lot of variability. Here's the regression line, but we have patients all over scattered around way up here. So there's individual variation. And of course, in complex eyes, post-LASIK eyes, the relationship between the front of the cornea and the back of the cornea is lost, and we really can't use regression formulas for that. And of course, in those eyes, it's also challenging even to measure the anterior corneal curvature and understand what values to use for our toric calculations. So my own data using the Baylor nomogram and the Abulafia-Koch, we've and hand-picking the power, the particular measurement, we got 93% within a half diopter. But that is a time-intensive activity. So does direct measurement of posterior corneal curvature improve our outcomes? We're always asking that question. Can we get rid of those regression formulas and use a direct measurement? And we can measure posterior corneal curvature using Scheimpflug devices, but all of the data that I have seen show no benefit of measurement with Scheimpflug devices. In fact, they don't perform as well as, for example, the Barrett or the Abulafia-Koch. OCT devices, we have many of them now, the swept source OCT devices that are measuring the posterior corneal curvature, and I'm really going to be interested to see what the Anturion does because of its measuring so many different meridians. It's going to be really exciting to see what it comes up with. And we already heard that the 700 IOL Master 700 measures at 6 meridians with, and it adds the total corneal thickness to the anterior corneal curvature in order to get total corneal power. So another approach that's interesting is to actually use reflection base, which is what we use for the anterior cornea, reflections of LEDs. In this case with the Cassini, the color LEDs measure the anterior corneal power and curvature, but the white LEDs that you see here, these 7, can be actually detected as the reflection off the posterior corneal surface. There's the anterior corneal, this is the posterior corneal, and I think it's going to be interesting as this technology evolves, and it's continuously improving, whether or not this might prove to be most accurate, because we do know that reflection technology for the front of the cornea, at least up until this point, has proven to be the most accurate way to measure anterior corneal curvature. There aren't a lot of data yet on using total corneal power with the IOL Master 700. Graham Barrett had reported on a few cases for post-LASIK eyes, and he showed that he got 68% within a half diopter using True K, but 75% within a half diopter using the True K toric in these post-LASIK eyes, so that measuring the posterior corneal curvature did help to improve his data. So our own data in looking at the posterior corneal curvature with the IOL Master 700 shows some improved accuracy in our toric calculations in eyes with against the rule astigmatism, but we did not see any improvement in eyes that had with the rule astigmatism. So we're learning still about what's contributing to surgically induced astigmatism and what really needs to be incorporated into our toric IOL calculation formulas. Direct measurement's getting better. It's where we want to go, but at best, it's still marginally superior to our regression formulas. What about intraoperative aberrometry? Well, I rarely use it actually for toric surgery. It is useful for those who do fewer preoperative measurements. It has a value. I think it has an upper limit to its accuracy because of all the factors we know measuring an eye after surgery has been conducted with altered corneal surface and corneal thickness and so on. And I think its role will diminish as our preoperative technology improves, and I think we'll see it someday become obsolete, but it still plays a nice role for many excellent surgeons. How do I align my toric IOLs? Well, you know, I'm still kind of a manual marker. I do like the Callisto, as I'll mention. We know that you have to align your toric IOLs within less than 10 degrees because a 10-degree misalignment introduces a 33% error. I like to make a pre-op drawing if I have one where I can draw some vessel, but on the day of surgery, I sit the patient up. I make marks at 3 and 9 o'clock, but my marks are rarely, if ever, exactly at 3 and 9 o'clock. So I make a note of where these marks are on a drawing. I take this to the operating room with me, and I then use that to align my toric IOL, so I know exactly where I'm aligned. And when we did that, we found accuracy, a mean accuracy of better than 3 degrees for all of our toric patients. We've heard about the high-tech options, the Callisto, the Varian, and again, we got as good a result for my kind of obsessive compulsive manual marking. That said, I love the Callisto. It's wonderful to have it right there in the operating room and to align the toric IOL with that. And we're kind of moving more and more to that technology. I think that we're going to eventually, ultimately migrate to that because it is faster and easier. But I'm not sure really, if you're really compulsive about your marking, it's that much better. What about post-LASIK eyes? I think this is interesting. We just reported this. Toric IOLs in our hands work out very well if you meet 3 criteria. You want a regular bow tie astigmatism within the central 3 millimeter zone, whether it's post-myopic or post-hyperopic LASIK. The difference in a corneal astigmatism, and in our study, was between the IOLMaster 700 and the LensStar, but it can really, I think, be between any of your measuring devices. If it's less in magnitude than at 3/4 of a diopter, as it is in this data set, and if the difference in the steep meridian is less than 15 degrees. And what I did in this, when I did these calculations, is that remembering that the surgically modified cornea doesn't tell you anything about the posterior corneal astigmatism. So for these eyes, I just estimated it was 0.3 diopters against the rule. And I targeted with the rule eyes for a little undercorrection. I leave them a little bit with the rule. Oblique eyes, full correction of astigmatism, and against the rule eyes, a little overcorrection, again, to leave them 0.3 diopters with the rule. Factoring all this in, we got in post-myopic LASIK eyes, 56 eyes, 80% within a half diopter, and post-hyperopic LASIK, 84% within a half diopter of refractive astigmatism. So that's actually been published now. What about keratoconus? Well, and radial keratotomy. In my mind, they really fit the same sort of criteria. They have to be stable. You have to have regular topography in the central 3 millimeters. You're not going to be wearing a contact lens post-operatively, and it's very important to sort that out with the patients. You don't want to put a toric lens in if they're going to wear a contact. And the spectacle correction with its astigmatic correction before the cataract, or when you can get a good refraction, gave good vision. If the spectacle astigmatism and the topographic and the biometric astigmatism line up relatively well with either RK or keratoconus, I'm pretty comfortable using a toric IOL, and we get good results with those. But I think that's what's interesting. It'll be interesting, I think, as this technology for keratoconus improves. I think ray tracing has a huge potential here because of the fact that it really will take into account all of the odd aberrations of the anterior corneas of these irregular, of the anterior corneal curvature in these irregular corneas. And of course, I think a very interesting approach for these corneas with advanced irregular astigmatism are things like the AcuFocus IC8 that you can put inside the capsule that are used in a lot, have been used with good success, particularly outside the US. Hopefully we'll get it soon in the US. And the Morcher Extra Focus is developed by Claudio Trindade in Brazil, and then made by Morcher. It's a very interesting add-on technology for treating irregular corneas. So what do we still need in our calculations for toric IOLs? Well, as I mentioned, we need better keratoconus, RK, post-keratoplasty measurements of our corneas that include the anterior and posterior cornea. We need to factor in IOL tilt, and I'm hoping that our new formulas will ultimately get there. We can measure the IOL tilt with the IOLMaster 700, but unfortunately the data have to be sent to Carl Zeiss in Germany to be analyzed. And we did a study. The first one came out from Oliver Shindo and Nino Hernschel, a wonderful paper. And we subsequently published a study that found that the crystalline lens tilt was 3.7 degrees, but up to 7 degrees. And this shows of the 6 cuts with the IOLMaster 700, this shows the cut with the most tilt. And this actually is the horizontal cut. And you can see that this is the nasal side and this is the temporal side. So the crystalline lens is tilted with the nasal side anterior. Why is that? Well, it's because the eyes turned out a little bit. And why is the eye turned out? It's because of the angle alpha. And why angle alpha? It's because we are placing the image on the fovea, and the eye has to rotate to bring the image onto the fovea. IOL tilt, interestingly, is more than lens tilt, up to 10.7 degrees in our study. It's nasal anteriorly, and what this does in this tilt is it actually induces plus power along the horizontal meridian. It's another cause of against the rule refractive astigmatism in our patients. So can you predict the IOL tilt from pre-op? And in 65 eyes, the pre-op was 3.6 up to 6.7. Post-op in these 65 eyes, 4.8 up to 9.3. And the tilt direction, this is the magnitude of the crystalline lens and the IOL. The tilt direction and magnitude is predicted by the pre-op crystalline lens tilt. So I think this is really exciting, and it's something we're going to see incorporated into our formulas. As we get better, we had a high R-squared of 0.5. And here's one patient, crystalline lens, IOL. You can see the similarity in the tilt. Well, what's the impact of this? Well, the impact, if you have a small amount of tilt of 5 degrees, it really doesn't induce much astigmatism. This is induced astigmatism from IOL tilt, in this case of a toric IOL. And you can see it's less than 0.2 of a diopter, but it is still some. But if you have one of these eyes that has a higher amount of tilt, let's say 9 degrees, you can get induced astigmatism of up to 0.6 diopters. And it's interesting too, and important to know that if you're aligning your toric IOL at 90 degrees to correct with the rule astigmatism, you get an increased effect of that IOL toric correction. So it creates more against the rule change. And conversely, you undercorrect if you're aligning the IOL at 180 degrees. So this is going to come into play as we move forward. I think we're really going to need a way to deal with so much data and prevent errors. We're overwhelmed with data. The point was made, there's a sort of diminishing returns about one measurement after another after another. And I think with so much data that we're acquiring, all the data entry, we need things to automate it. And I think programs like Veracity and others that are in development are going to really be important for us going forward. And this is just an example of this one program, Veracity from Carl Zeiss, where it imports all the refractive data, look at all the K readings that are incorporated here. You can then have a surgical plan that you can take to the operating room, and then actually you can just post this on your screen so you know exactly what lens you're putting in for a given patient. And then you can generate operative reports and do a lot of things with it. I think post-operative adjustment is going to be important, whether it's something like the RX site technology or localized refractive index change, refractive index shaping with companies like Perfect Lens and Clario. The beauty of this RX site is that it's incredibly accurate, but you must use their material and their lens. With Perfect Lens and Clario, if it ever comes to fruition, you can do it really on any IOL. So I want to close by talking a little bit about how we analyze astigmatism outcomes. Astigmatism is complicated. Astigmatism has two variables, power or magnitude. And you can't, so let me just pause that here, go back here. Okay, you can't solely or add or subtract values when you're analyzing astigmatism. You can't analyze vector magnitude alone, and you can't analyze vector angle alone, as is done in a program like a SORT. You have to combine them, because if you don't use the two variables together, you can get misleading results. So, so you can't oversimplify it. When you analyze astigmatism, we break it down into two variables, the X and Y components. We perform calculations on them separately, and then we reassemble them back to the astigmatic value. So how do we make it more straightforward? We want intuitive terminology. We want data that are clear and complete. And in our guest editorial, we proposed simple terminology, and we described the figures that we think are used or needed to best display our astigmatic outcomes. Surgically induced astigmatism can be described as the predicted, the actual, and the prediction error. The components are the corneal component, the IOL component, and the total. And those are very simple terms. And for IOL surgery, it's the predictive postoperative refractive astigmatism, the actual, and the, so we have these are the same terms we use for evaluating IOL calculation formulas. And our spreadsheet creates 3 figures. There's a cumulative histogram, percentage of eyes within certain amount of dioptric error, which is, of course, the bottom line for what we want with our corrections. And then we have, how do you display it with both magnitude and meridian? And you can do it with single angle plots or double angle plots. This is a single angle plot, very intuitive because it looks like our 4-opter. But if you take those with the rule and you double them and move them around and the against the rule and double them, then we group all of the data together so that we have, as you can see, with the rule here and against the rule here. And that's a very attractive way to group the data once you understand that the with the rule are to the left and the against the rule are to the right. It just requires us to kind of rethink how we look at these images. So here's a single angle plot of some data. Looks like a 4-opter, but you don't really know what the data show. With the same exact data points, double angle plot, you can really see that they're grouped on the against the rule side. Remembering this is the 0 side, the against the rule side, this is the with the rule side. And here, for example, here's a data set of pre-op corneal astigmatism, post-op refractive astigmatism. You can see how elegantly it shows the 95% confidence ellipse for the pre and post-op data and the centroids of the data in that data set. And so you can look at pre and post with this. We generate a lot of data from it. And very importantly, you can look at the prediction error, which I think is what's so important. This is the prediction error of a Toric IOL set with just using anterior Ks. You can see that it has an error on the against the rule side. And when we introduce a formula like the Abulafia-Koch or the Barrett, you can see that all of a sudden we have a centroid that's moved from against the rule here to with a centroid amount of 0.55 to right around 0. But notice the standard deviation is just as large, but a very nice mean correction of the astigmatism. And the percentage of eyes within a half diopter goes from 31% to 77%. This spreadsheet is available, very easy to use on the ASCRS, JCRS, and ESCRS websites. Here's where you find it on the ASCRS website. Very easy to find and very easy to use. I think the double angle plots are highly informative. They're easy to understand, but you've got to grasp the concept that of the doubled angle, that the with the rule eyes are grouped over here to the left and the against the rule eyes are grouped over to the right. And I believe that this is the optimal way to display astigmatic data. So looking back then and thinking about our Toric IOL patients, I think it's going back to the patient, him or herself. It's really important to hear patients' visual complaints postoperatively. And we have to learn, of course, to be not satisfied with subpar distance or near vision in these patients. We have spherical error, we have astigmatic error. And one thing we may not have a chance to cover, but of course it's so important to be willing and ready to treat any errors you encounter. And I want to thank you for your attention and for the real honor of speaking to all of you today.
Thank you so much, Doug. It was really exhaustive, and it really gave us a very good idea about what is the frontier work that is happening, and that is in your clinic. And we have 2 more topics to go, but I think before Ramesh comes on the screen, we would like to take some questions for Doug. Sri Ganesh or Dr. Mahipal?
Yeah, excellent presentation, Doug, and always enjoy your talks. One of the studies that we did looked at surgical induced astigmatism and white to white, and we presented this in APACRS Bali. It got the best poster. And I think that is one parameter which probably affects the induced surgical astigmatism, a variable, and that should be taken, because if you have a larger, what we found is if you have a larger white to white, then the surgical induced astigmatism is less when compared to a smaller white to white, because the cord length of the incision relatively is smaller or bigger. So that is something that can be also looked at in incorporating into the formulae. And the other, of course, is the elusive effective lens position, which can affect the toricity, and your refractive results with Toric IOLs can be off because of the ELP.
those are great points. Shri, I'd love to get copies of those slides about your cord length and the corneal diameter. I'd like to, I think that'll stimulate us to look at ours as well. That's a great insight.
Doug, I have a question for you. Like, for example, what would be your take-home message? What would be the 2 or 3 formulas to go to in terms of, toric IOL calculations?
It depends what device you have and what's available to you. The Barrett is fantastic. Graham's done a wonderful job of that. Studies that have compared that to our Abelafia Coke, they're pretty much similar. The Hill RBF uses the Abelafia Coke, so if you're using the Hill, you can use that. If you're using the Barrett formula, it's built right into the Barrett formula. The Holiday 2, if that's the formula you use, it has a good toric calculator built into it as well. I know that Kane has now come up with a Toric IOL formula, and knowing the kind of nice work he's done with his other formulas, I bet it works very well. So those are the ones that I like and would use. You can use the manufacturers like the Johnson & Johnson and the Alcon, but those require you to enter data again into another website or web page, and that as a risk of introducing error and takes time. So I would use those that are built into your biometer and with the IOL calculation program that you have, and you're going to do fine.
Doug, we are going to have a part 2 of this same webinar a couple of weeks later. So I would invite you to join us, and I'll be in touch with you regarding, the possibility of taking up 1 or 2 topics. And Dr. Mahipal or Dr. Namrata, any questions before Sri Ganesh starts his presentation? Before Ramesh starts his presentation?
I think it was a great talk. It's always a pleasure to listen to Dr. Koch, and I think you've already taken a commitment from him for the next time, so that's good. But I think it was an excellent presentation.
Thank you.
So on a public platform, he can't say, no, I'm not going to be there, or I don't know.
Okay. So thanks a lot, Doug. And then Ramesh,
Doug, the other biggest issue is post-RKI. So what is your suggestion for?
Those are the questions we're taking up in the next webinar, Sri Ganesh.
Oh, okay.
Yeah. Post-classic, post-RKs for the next
all
time.
those unique and complex situations are coming up in the part 2. Yes, Ramesh.
Okay, thanks, Arup. And thanks to Dr. Doug Clark, because this is an absolutely mind-blowing talk. And I just remember this last talk that I heard when he spoke about the Kelman's lecture in the ACRS. For a lifetime, I think that is the most wonderful talk I ever heard. And then the next one is today's. So my topic today is on effective lens position. Arup, can you hear me? Arup, can you just confirm you're able to hear me?
Yeah, we are able to hear you.
Yeah, we are able to hear you. I was muted actually. We are able to hear you, Ramesh, very well.
Thank you so much, Arup. So I have these 3 topics to cover: ELP, IOL, public health, and manufacturing tolerances. So before I start, we should thank all the great ophthalmologists who helped us with the power calculation, with a special thanks to Dr. Wolfgang Hages, only non-ophthalmologist in this group, who passed away last year, who has done pioneering work, and every one of them has helped millions of our patients in all parts of the world. ELP, variously termed as estimated lens position or the effective lens position, is a term used to denote the position of the lens in the eye, and it's a distance between the principal plane of the intraocular lens and the cornea. In a standardized pseudophakic schematic eye, it is defined as being 5.25 millimeters behind the corneal vertex plane. And the lens position should be fairly easy to measure, because we can easily measure the corneal thickness with current instruments. We can easily measure the anterior chamber depth with great accuracy with current instruments. But how do we guess the position of an intraocular lens that is 1 millimeter thick within a 4 or a 4.5 millimeter capsular bag? We can easily measure the actual lens thickness accurately, but the holy grail of biometry, final position of the intraocular lens, the ELP. Over the years, many different variables have been used to calculate. In 2008, Nobel showed us that there are three major reasons for errors in IOL power calculations. 1/3 of the errors are a result of axial length and corneal K reading measurements. 1/3 of the error was because of errors in estimating the ELP. And the final third is errors due to mistakes that we make in post-operative refraction. It's interesting to note that both axial length measurement and K reading can contribute to ELP errors. Last year, Wolfgang Hages remarked that axial length measurements have reached a very high level of accuracy, and today we can actually measure the variations in the axial length in different parts of the day. It's unlikely that these measurements can become more accurate in a meaningful way. For any given position of a lens in the eye, the actual power depends on the lens diopter, the lens thickness, the shape factor of the lens, whether it is a meniscus lens, a planar convex lens, a biconvex lens, and finally and most importantly, the corneal power. We know that the corneal power is an approximation. Here is just my posterior corneal measurement in 3 mm, 5 mm, and 7 mm rings. And you can see the wide variation in both magnitude and axis in any given eye. All those are not dependent on us, but we have three major surgically induced factors which will affect, surgeon-induced dependent factors that will affect ELP. And the most important of these is the rhexis overlap. We should aim for a 0.5 to 0.7 millimeter 360-degree overlap of our intraocular lenses. Severe capsular phimosis like this can alter ELP, as can a large rhexis like this. This can permit the intraocular optic of this three-piece lens to move out of the bag, move forward, and change the ELP. The second factor, which is in the surgeon's hand, is your choice, whether you choose to put a three-piece lens or a single-piece lens. A three-piece lens has got haptics that's angulated anteriorly. In the post-op period, as the capsule shrink wraps and it compresses the haptics, the optic can move forward in three-piece lenses. With a planar single-piece lens, this problem does not exist. And again, if you choose to put an intraocular lens with an anterior offset as against a planar design, your results can vary. Now, let us see what happens when I move this plus 20 diopter lens in a lensometer by about 2 centimeters. So what happens is the power of the lens of this 20D lens can vary from 20 to 24.75 diopters. Similarly, inside the eye, when our intraocular lens moves inside the eye, Olsen taught us in 2007 that minor variations can cause changes. Look at this 0.25 millimeter movement of a lens inside the eye. This is half the thickness of the cornea. If the intraocular lens moves 0.25 millimeters in an average eye of around 22 mm in length, we can get a post-op error of up to 0.4 diopters. In a myopic eye, the same movement will cause much less of a difference, while in a hyperopic eye, in a small eye with a 20 millimeter axial length, the difference can be as high as 0.5 to 0.6 diopter for a small 250 micron anterior shift of the intraocular lens. The lens material and the haptic design can also affect the effective lens position. This interesting article by Laura Raymond et al. Showed how the intraocular lens optic can move forward when the haptics are compressed by as little as 1 millimeter by capsular fibrosis. In this set, you can see that there are C-shaped looped lenses on the left and plate haptic lenses on the right. And this is very easy to see. When you have a 1 millimeter compression, there is no or very, very minimal change in ELP when you have a C-looped intraocular lens, while the same 1 millimeter compression of the haptics can cause quite dramatic 1 millimeter or more anterior displacement of the optic if you choose to use a plate haptic intraocular lens. So plate haptic intraocular lenses have to be made very rigid to resist these kind of movements. In summary, a 0.25 millimeter change in ELP can lead to a 0.3 to 0.5 diopter in error in normal and short eyes. We have reached the engineering limits of measuring the axial length, and we must find a better way to measure corneal power. There are physiological variations in anatomy and in healing that contribute to ELP error, and some of this cannot be taken care of by better quality instruments. My next topic is on IOL power tolerances. It's interesting that all our lenses are made as per ISO standards, which were defined in 1999. And what do these standards say? For the usual lens that we use with a power between 15 and 25 diopters, they permit a 0.4 diopter of error, and they pass them. This is the actual FDA approval for a multifocal lens, which was approved in 2014. This particular lens is widely being used in various parts of the world. And here we can see the optical requirements, and the FDA has passed it. And here we can see that they have used the same criteria, 15 to 25 diopter. They have tested to see whether the spherical equivalent of this multifocal lens was within 0.4 diopter, and they have passed this lot of lenses. We are using these kind of lenses. The ANSI standards for toric lenses are very similar. They specify that the ivoid spherical and cylindrical combined error should be within 0.3 to 0.5 diopter. Also, that the axis should be marked within 5 degrees of the actual orthogonal cylinder of that intraocular lens. And the rotational stability should be within 5 degrees for 90% of the intraocular lens over a 3-month period. Several companies that offer intraocular lenses in India were asked about their manufacturing tolerances. None of them are willing to share the data for this presentation. I think this information is quite important to us, and I request AIOS to formally request this data. What is the tolerance that they apply? Is it as per ISO standard, or do they have tighter tolerances in the lenses which they supply to us? So what is the true power of a lens when it is marked plus 20D? In 1996, Savakanopi et al. Determined the power differences when a lot of lenses were measured in different labs. And they found that less than 1% of the dioptric power was the average difference between various labs. What this means is the same lens can be measured at different labs, and they can give an error which can be up to 0.2 diopter for a 20 diopter lens. Kenneth Hoffer used the US FDA optical testing lab using a more advanced confocal laser method to find out what is the variation of exact power labeled intraocular lenses. And he found something very similar. When a company marked the exact power on those lenses, this was a company which supplied lenses from Europe, and he found that the error was 0.18 with a standard deviation of 0.12. So though they were marked with the exact power, the actual power could vary by 0.2 or 0.3 diopters from what is stated on the label. He also found that in these hydrophilic lenses, when the temperature was raised from 22 to 23 degrees, the actual power increased by 0.13 diopter. So there seems to be a wide variation between different labs and what is in the lens and what is marked on the box, and I'm sure more work can be done on this. The last part of my topic is on IOL power steps. We all are aware that we get the power steps in 0.5 diopters in the usual ranges, and in extreme powers, they're available in steps of 1 diopter. Toric lenses are usually available between 1.5 and 6 diopter in 0.75 steps. A small group of vocal surgeons believe that we should get intraocular lenses in 0.25 steps, and this will make our results more accurate. Dr. Warren Hill strongly feels with the current technology it's not needed, because the actual power of a 0.5 diopter lens inside the eye, the lens power, the effective power is only 0.37 diopter in the spectacle plane. If you implant a lens with a 0.25 diopter step, the effective power in the spectacle plane will be a 0.17 diopter, and we do not refract in 0.17 steps. So this will not be of much use to us. In 2005, Technomed, a German company, started using the exact labeling method, and we know that LensTech HD is also supplying hydrophilic lenses, and they claim to have a manufacturing tolerance of 0.1D. When these lenses were implanted, various surgeons have shared their data, and they showed that up to 84% of their post-ops will be within 0.5 diopter. And for the lens and soft HD lens, Hunter Newsom presented that 70% of his post-ops are within 0.5 diopter. As most of us are able to achieve these levels with our regular lenses, the need for a 0.25 step has not really picked up. So power calculation is a multi-step process. The weakest link currently is not measurement of the corneal thickness, the anterior chamber depth, the lens thickness, or the axial length. We are able to get very accurate measurements of these. The weakest step is estimating the ELP as well as measuring the true corneal power in the visual axis and not on the corneal vertex. So I think these have to be taken care of before we start using lenses in 0.25 power steps. So in brief, I have covered the ELP, power steps, and IOL manufactured tolerances. And if you have any questions, I'll be happy to take them. Thank you.
Thank you, Ramesh, for your extensive literature search and the resultant presentation. So I'd request Dr. Girish to come on the screen. And any questions for Dr. Ramesh?
Yes, I have one quick question for Dr. Ramesh. The ELP calculated is usually on the basis of the anterior chamber depth, and different instruments calculate the anterior chamber depth differently. One is from the anterior surface of the cornea to the anterior surface of the lens. One is from the back of the endothelium, that is the true aqueous depth. And since after refractive surgery, the thickness of cornea also changes. So which one would you suggest would be the best to have the ELP power out of all these?
I would suggest that we use the latest formula, like a Barrett True K formula, and in that it asks you which instrument you're using to do your measurements. Okay. So if you're going to use your measurement like an IOL Master 700, it will straight away take the measurement from the anterior cornea, and then it will continue to measure. If you take Pentacam, it will take the corneal thickness from there. So it all depends on the instrument that you use. We don't have to manually select this. Choose a very good formula, preferably online Barrett's formula, and choose the instrument that you are measuring with, and let the formula do the work for you.
Okay. Dr. Dog, any comments from you? Any inputs on this?
Well, I thought this was can you hear me okay?
Yeah.
Yeah, I thought that was a really, really superb talk. And it covered so many nuances. I think one of the problems the lens had was that it was a hydrophilic acrylic. I used it some, and the effective lens position was all over the place with that lens, it would cause a lot of bag contracture, and the lens would come forward or back. So I don't know that we can judge the accuracy to within a quarter diopter with that lens, because I think it's the wrong platform for it. And I think we're getting close to the point now where maybe we can start to think about quarter diopters because we're doing so well. But I thought that was a fantastic talk.
In fact, actually, the guest editorial that we had written, Doug, actually, one of the recommendation was it is time for the industry to, to start manufacturing lenses with shorter dioptric steps. I think this holds true only for those surgeons who are consistent in getting the postoperative refractive range in more than 90% within 0.5 diopters. I think that may be, if you're getting more than 90-95% of patients in that range, perhaps one could think in terms of a 0.25 diopter step. Otherwise, it may not really make that much of a difference in the routine surgery.
Yeah, the one thing we haven't mentioned also is just the error of refraction. And that was pointed out by Norby, that the postoperative refraction that we do, if we're delegating it to a technician who might not be a good refractionist, that throws all the data off. So there are just so many points along the way that errors can be introduced. But I thought that was, again, a great talk.
Thanks a lot, Ramesh.
I just have one comment. I think ELP is going to be a very difficult problem to solve, because the ELP again depends upon the capsular bag size, the size of the rhexis, etc. So I think the ideal solution would be to fix the position of the lens. Like the capsulotomy fixated IOLs may be a good solution for ensuring that the ELP is constant. And we have designed a lens. It just got the US patent. And there we have done studies where we have done the antechamber depth over 6 months, and then it's remained constant in about 50 lenses. So I think this could be the ideal solution for ELP.
That's a great point, because there was a paper by Oliver Findel's group that looked at C-loop one-piece lenses and measured effective lens position in 20% of the eyes. The IOL shifted in position by 1 millimeter or more between 1 hour and 3 months. So that's, we don't know which of our patients, you know, we all have our patients who are 20/20 and day one, they come back at 3 weeks and they're -1 and unhappy. So something like you've proposed, Sri, I think is going to be critical.
Exactly.
Thank you.
So we now move on to the last topic, last but not the least, a very important topic, a constant optimization. And over to you, Dr. Girish.
Good evening. Can you hear me, Dr. Arun?
Yeah, we can hear you.
Hello,
Yeah.
Dr. Arun, can you
We
hear
can,
me?
we can hear
you.
you. Yes, yes.
Yeah. Thank you for giving me an opportunity to take part in this webinar. My topic is a constant optimization in IOL power calculation. Now, cataract surgery is now a refractive surgery. So patients' expectations are higher, and precision in IOL power calculation is very important. Even after doing the careful calculation and very good surgery, patient may end up with some residual power. If the surgeon uses optical biometry and modern techniques but does not optimize, he may have one diopter on myopic or hypermetropic side. Here we can see the comparison of the two charts. In first one, there is non-optimized A constant, and on the right side there is optimized A constant, and there is a 4-fold improvement in the results. So optimization is very important in A constant, getting a good A constant. Here we can see that the Barrett has a more variable and it gives a more precise A constant. So why we should go for A constant optimization? First is there could be error in biometry, there could be error in keratometric index, selection of formula, and A constants, as I said now, and surgical factors. It is said that, and it is proved that when we do the biometry, non-optical biometry has more errors, and optical biometer with good standardization and measurements, they are more precise and consistent between the two instruments. It means when we use when we check the axial length in different optical biometer, they are more consistent and more precise. Looking to the keratometry, it is very well known that the cornea is steeper in the center than in the periphery, and different instruments measures different area of cornea. Like that, the American optical keratometry, which is very old, it measures 3.2 millimeter apart and which measures 44 diopter, whereas the IOL Master is of 2.5 millimeter apart, which measures 0.70 diameter higher than the American optical keratometer, whereas the Heck-Street lens star, which measures still smaller area, which is 1.8 to 2.2 millimeter, and it is still higher and it shows the steeper cornea. So in short, the different area has a different power, which should be kept in mind when we optimize the IOL A constant. Similarly, do not mix the different keratometer, is said earlier also, that when we use the IOL Master, use keratometry of IOL Master only, don't use keratometry of other instruments or manual keratometry. Second thing is keratometric index. Now it is also known that in the United States, they use the keratometric index 1.3375, in Europe 1.336 or 1.332. So there are different keratometric index for the different instruments, and as a result, 7.5 millimeter radius of the corneal curvature in the United States is a 45 diopter, in England it is 44.8 diopter, and in Germany it is 44 diopter. So there are different machines are measuring different index, and there are few keratometric index we can change. It is facilities there in a selection in IOL Master 700 and other machines that the N is 1.337, it can be changed to 1.336 or 1.332 or 1.3375 as per your selection. So this facility is there when we optimize the A constant. Over and above this, there are some surgical factors like any surgical steps which may affect the final EAP, which is just discussed now in a previous lecture. And capsulosis size and centrations are very important, incision size and position, and inadequate OVD removal. So these all affects the A constant. Even it is said that when you change the post-operative steroids regimen, then also A constants can be changed in different scarring in different patients. There are, as I said earlier, the variables, the multiple variables has a better results than the small amounts of variables like in old formulas. So the recent formula like Barrett and Hill-BR, RBF has better results than the less number of variables in the A constants. Now it is when the new lenses come out, the manufacturer does not recalculate it, and they just transfer the constant from the similar lenses. Like I used the Technics 1 lens in past, and now I use the Technics IHANS. Both have the same A constant, but it is fact that the change in IOL geometry may change the A constant. So optimization is very important. State that these A constant derived and supplied by manufacturer are not definitive. So there are chances of error of a point diopter. So personalization or optimization is very important in constant thing. Now not IOL 700 has an inbuilt A constant optimization. The NIDEC can also has an inbuilt A constant optimization, like also in a Lenstar 900. But in case if you do not have this inbuilt software, we can go for optimization in a few websites like IOLcalculation.com or IOLconstant.com or ULIB, which are the free websites. We can measure the or personalized A optimization. Holiday IOL constant software, which is also available, but it is paid. Similarly, Analyze OR technology is also paid, and Zeiss EQ Workspace is to be used, but it is also paid. So this is the special, EQ Workplace is for Zeiss, IOLmaster 500 and 700 and Callisto. But there are few good optimization softwares and Excel sheets are available by Dr. Warren Hill, where you can optimize it very easily, and it is also free, and minimum you have to enter the data about the 200 eyes and preferably more than 300. Similarly, I also have used Dr. Saurabh Sawhney's Excel sheet, which is also free, where we can get the data instantly. Whereas in Warren Hill, you have to email the data and we get the personalized A constant. In Saurabh Sawhney, we can get the optimization instantly. And here the more than 50 data are enough. Now, how to go ahead for this optimization? What we need to collect the data about 200 patients, same model of the IOL, uncomplicated surgeries, good quality of preoperative measurements, and as said earlier, the total K or true net power, which means the posterior corneal curvature measurements, optimizes better. 4 to 10 week postoperative reflection, which should be 6.9 or 6.6 in all cases. Size and site of the incision should be same, preferably temporal, and we have to enter all this data, including postoperative reflection, into Excel sheet supplied by the optimization sites. We should avoid the bad quality measurements of abnormal ocular dimensions, more than one surgical procedures, and we should avoid the toric IOL, even the extended depth of focus IOL, because it may mix up the results. In my case, I have used a Saurav Sony sheet where I could get a 1.113.33 A constant, which is my personal optimization compared to the company's A constant supplied 113.119.3. So there is definitely some change in personalization. Whereas in when I entered the data in Dr. Hills for iHans, it was 119.32. So in Sony it was 119.33. Here it is 119.32. So this is what I got the personalization, and I got better results. So advantage of optimization is you have a significant difference because it does require the time and effort, but the results are good, and you fall within the 0.5 diopter of the residual error. This is helpful when you are dealing with a short eye, and it has a great change in the results. But keep in mind that this is not a one-time exercise, because you have to do this exercise repeatedly, as such customization is an ongoing process, and there's much to do. And when you change the surgical technique or you change one of the instruments, you have to do this exercise again. Thank you for your kind attention. Thank you.
Thanks a lot, Dr. Girish. It was quite well covered, and I'm sure a lot of junior surgeons are watching, and they'll definitely be benefited from whatever you have said so far. My question to the panelists would be, how many of you do your A constant optimization for routine surgeries? Dr. Sri Ganesh?
Yeah, I do a constant optimization for all IOLs, and I think every surgeon we need to do a constant optimization, because again surgical technique can vary, and this can also give rise to a little bit of change in the post-op refraction, like the size of your X-rays, etc. So I think every surgeon should have their own A constant for each lens, and then enter it accordingly.
Yes, I also do a constant optimization, but there's one more thing, that is the centroid. We should also look into not just the amount of the refractive error, but also the induced astigmatism, the change in the axis, because sometimes when you're doing the right eye, you may be slightly supratemporal, sometimes you may be dead temporal. So you should also look at the induced axis change also.
Exactly.
That I also do. Yes.
So Doug, what is your take on this? I mean, how do you go about this issue?
Well, I'm going to be a little contrarian about this, which is to say, I think we all need to look at our outcomes of our IOLs and how accurate we are. But there are a lot of things that go into our constant optimization. One of them is the lane length, and are we refracting at a 3 meter, 4 meter? Are we adjusting for 6 meter? And I think that if we're doing what Shri talked about, which is we have a consistent capsulorhexis that is the same. I mean, let's face it, most of us do just about the same thing, don't we? We do have a 2.4 millimeter incision. We have a 5 millimeter capsulorhexis. The lens is in the bag. And unless there are racial or national or whatever differences, as a Caucasian eye different from a South Indian eye, from a North Indian eye, lens optimization may not be as important as we used to think it is, because we're doing so many more things systematically. Now, that said, different countries and different races and so on, I think, could come up with actually different constants. And in that respect, it might be very valuable. We think that the different types of Asian eyes may respond to different types of Caucasian eyes, etc.
So I'll give an example. For example, if I use the Barrett calculator, Universal 2. So how do you do your A constant for optimization for Barrett Universal 2? Because that is not a published formula.
Yeah, we don't.
So we can't do it. So most of the formulas that we're using, maybe for Hill RBF perhaps, but I think, but he has his own A constants for all the lenses. Same thing about Barrett, ULIB.
Right.
So earlier, about 10 years back, I was doing my A constant optimization routinely for most of my patient surgeries. But now I have realized, and I have learned a great deal from teachers like Doug and others. That. So now, since the surgical technique is more or less constant, the lens that we are using have international footprint, and huge number of lenses have already been fed into the software to get the A constant. So I think that has been giving us a very good results. Only problem occurs when you're dealing with a new Indian lens. So that is a type of lens which usually will not be present in those formulas. They will not be part of those formulas, and then there's a problem. So those cases are definitely do it manually. I do 10 cases and then change the A constant if necessary, either down or up by 0.1, and then wait for the 10 cases, and it takes a lot of time.
Arup, sometimes you can have lens mislabeling, and then it's very difficult. I'll tell you a story which is very interesting. Indian manufacturer, we got a lens, and then we were getting results which were totally off, only with this lens. All the other lenses were fine. Only with this lens, it was totally off, like 1.5 diopters off. And then we checked everything. We checked our biometry. We checked everything, and everything was fine. And then we actually went back and investigated, and finally we found out the source of error. And you can't believe it, because the lens measurements were done with a lensometer. Okay, after the manufacturing, the labeling was done with a lensometer, and we found that the person who was doing the labeling had a refractive error, which was not corrected with the eyepiece of the lensometer, and this was resulting in the lenses being mislabeled. I mean, you can have things as crazy as this.
See, was the surprise hyperopic or myopic? Hyperopic, I feel, because I have got the same. Yeah, I know which lens you're talking about. I know exactly which lens you're talking about.
So I think we have had a great day, and almost 3.5 hours have gone by. Time has just flown, and we have had lovely lectures. I think with Dow contributing so much on the toric intraocular lenses. So shall we call it a day? And we look forward to the second part of our IOL calculation webinar. So I'd like to thank Nazneen for helping us out with the conduct of the program. I'd like to thank all the speakers, for Dow getting up early in the morning, and all the Indian speakers. I think you have not taken a dinner like me. And it was wonderful, associating with you and drawing out with this program. And I hope it was beneficial to everybody. This is also recorded in our YouTube as well as Facebook. So it will be streaming, and recorded version also will be available for those who could not watch it live. And with these words, I would like to say good night to all of you.
Good night
good
to
day
you
to
also.
Doug.
Yes, thank you.
Thank you, sir. Good night.
Thank you.
Good
Dr.
night.
Roop, thank you again for
Good night.
giving an excellent webinar. Thank you.
Thank you.
Thanks a lot. Thanks a lot, Manju.
Good night, sir. Good night.
Good night, everybody.